All those in favor?
Aye.
Any opposed? And we have some recognition today. It's a new program, I understand, called Star Performer. And Sadie, you're in charge of this.
So I'm the Vice President of Quality and Patient Safety. In the last couple of months, we've created a Star Valley Health Star Performers Program. This program is to recognize our employees who exemplify compassionate care, every person, every time. Any employee can be nominated by another staff member for the award. Every month, our Employee Appreciation Committee reviews all of the nominations for that month, and they make a vote on a winner. The winner receives a star pen and is recognized here at our monthly board meeting. I'm very excited about this program, and I want to thank Mandy Lancaster for initiating the development of the recognition program. We have so many amazing and talented individuals that work here at Star Valley Health who deserve this recognition. I would like to recognize our two winners for the first Star Performers program, Karen Burton and Becky Hepworth. Karen, if you will please come up and join us. So Karen is a dedicated nurse who works in our discharge planning. She has been a value member of our Star Valley Health team for over 7 years. Karen was nominated for going above and beyond her role to support a patient and their family during a critical time. So here's what the staff members wrote about when they were nominating Karen. Karen is always going above and beyond to help our hospital and patients. Even when she is not working, she's calling to find out if we need anything and is always doing everything possible to make patients and the hospital get their visits covered and what resources we have to help them. Just today, I had a patient who was on a tour bus and was admitted to the hospital with chest pain. The patient ended up staying overnight in Afton and was stranded without a ride back to Alpine, where his hotel and his wife were. All I had to do was ask Karen, and she was more than willing to drive them back to Alpine. She hurried and got all of her work done so that she would have the time to drive them to Alpine. The patient and his wife ultimately needed to go to an airport. Karen also happened to be traveling to Idaho Falls that afternoon for a flight herself and very kindly volunteered to take them with her to the airport as well. Karen constantly does things like this for patients, and I appreciate her willingness to go above and beyond.
Congratulations. Thanks for the nice job. Appreciate it.
Okay, our next recipient is Becky Hepworth. So Becky is a skilled lab technician. Becky celebrates 10 years with Star Valley Health. Becky received not one, but 2 nominations for her outstanding teamwork, leadership, and commitment to excellence in her role. Here's what staff members wrote about Becky. Becky went above and beyond to help teach me while I was going through clinicals. She patiently took the time to sit with me and help me understand not only how to do something, but why we do it that way. She was also helpful in pointing out ways I could improve in a constructive manner by showing me why it is important to perform a task a certain way. She is a great coworker and mentor. And then another staff member wrote, Dr. Hauser has recognized Becky for her outstanding work for an L&D patient that required 4 units of blood, FFP, and lots of lab tests in the early morning hours. She remained calm, positive, and extremely helpful throughout the process. Nice work, Becky.
Thanks for all you do.
Good luck, sir. Get a picture.
Oh. Say no. Thorn, back to the roses. Thanks. Oops. Sorry.
Sadie, how did you get out of that picture?
strategically.
Okay, moving on. We definitely appreciate all of our staff, especially those that are going above and beyond. I think there's a lot more than the ones that were just awarded, but and we'll hear more about that. I think this is an ongoing program, right?
Yep.
Great. Okay, we're ready to have our education. It's about growth strategy, and then it looks like we'll talk about our strategic plan after the presentation. Is that correct?
That's correct.
We'll turn some time over to you, Dan.
Thank you, Mr.
You
Chair.
can either stay here or wander the hall.
Is it all right if I do it right here?
Yeah, I said either stay here.
Okay. If the board will remember, we met and received some training in San Antonio at the American Hospital Association annual convention, and we discussed numerous aspects of healthcare and the dynamics of healthcare and what is impacting healthcare at a national level, but even more importantly, what's going on here at a local level. And every hospital and health system on a regular basis goes through a process of educating, involving, and formulating a plan that makes sense so that people within the organization understand where we're going and how we're going to get there. And so the strategic planning process is a vital, it's just very, very important for any organization. I've included in the board packet a slide presentation of what we've formulated to help put on record, share with the board, and even more importantly, share with our staff where we're going and again, how we're going to get there. The one slide that I would like to make mention of at the very beginning is our strategy articulation map. This doesn't change that much from year to year, and so if I can just go through the down button.
There you go.
This is what I'm referring to. The strategy articulation map at the very top, it has our strategic direction, which gives our mission, which we've updated to compassionate care, every person, every time. That is one change that we involved all the staff to submit their ideas about what is their individual purpose, and then we captured all of those inputs from our staff, and we found a common theme that people want to provide compassionate care, every person, and every person is beyond just the patients. It's our fellow coworkers, it's the family members of the patients, it's our vendors, it's community members, and then the consistency was captured in the phrase every time. Our vision and our values. Those two we haven't adjusted since the organization came up with them. The next row underneath that is our strategic differentiators. And you can see that we divided up our strategy into 5 main pillars. And those pillars are loyal patients, service line growth, best people and culture, operational excellence, and fabric of the community. The strategic differentiators underneath those pillars are personal, loyal patient relationships. We think that can differentiate our Star Valley Health from competitors in the area. We can then, under service line growth, what we can differentiate ourselves from other critical access hospitals, other facilities, is a strong regional brand in the services that we provide. And I'll touch on that because that's an important part of the strategy. that some people may have differing opinions, especially those that feel that Star Valley Health should just stay in the valley versus what we're currently doing of having a presence and access points that are outside of the valley. And that's why I wanted to specifically highlight that strategic differentiator. And then we want to be a magnet for exceptional talent to this area. And there's certain barriers that allow that get in the way of us being a magnet for exceptional talent. And I'll highlight one of those, and that's housing. And then there are certain things that help us to become that magnet for exceptional talent. And I would say that there's certain things that about the valley that really attract some exceptional talent. The work-life balance, the culture of a small facility, the people that they work with, the independence of Star Valley Health are some of those strategic differentiators that help with us being a magnet for exceptional talent. Financial strength, obviously, if we're not financially strong, the other pillars are weakened. And then lastly, enhanced patient access and coordination. And so as we're trying to build a network of access points and a delivery system that is comprehensive, we want to make sure that handoffs are taking place appropriately and that we're getting patients to the right place, again, at the right time. Once you have your direction, your strategic differentiators, then you have your objectives. And again, they align with each of those 5 pillars of providing an exceptional experience to every patient every time, focused development, expansion, and sustainability of services. We added sustainability of services because as an independent hospital, that is really what is at stake for critical access hospitals that are independent. We brought up in past meetings that other facilities in our area are actually scaling back the services that they offer. And that's for various reasons. It could be financially related. It could be that they can't attract the talent. All of these things are not mutually exclusive. These pillars, there's a symbiotic relationship that takes place with each one. And so we added sustainability of services. We want to attract, acquire, develop, and retain the best talent. And those are all important steps. You not only have to attract them, you got to acquire, you got to develop, you got to train, and you want to also retain the talent that you put an investment in. And everybody knows that it's a lot of money to have turnover. Turnover is very expensive, and it consumes not just financial resources, but other resources from our existing staff. And so that's how we've articulated those strategic objectives. Then we want to optimize our operational effectiveness and efficiency and increase market share and brand awareness and relevance. And that aligns with that last one aligns with our pillar of being the fabric of the community. And then there's the strategic pillars that I already mentioned. And underneath those strategic pillars are our strategic initiatives. So here's where we're going with our direction. Here's how we differentiate ourselves in the market. Here's our objectives. Here's the pillars. But what are the initiatives under each of those pillars? And one of the things that we changed based off of the changes that we've gone through with converting over to Epic 2 years ago, the conversations we've had internally and amongst the board is notice that we added the word billing experience. So it used to be care experience, but we want to do care and billing experience. We think that our focus on making sure that is a strategic driver, so that the dollars and cents associated with healthcare and how people interact with that is the care the exceptional care that we're providing matches an exceptional billing experience as well. Service line growth, we have various service lines that we're focused on. You can see through our medical staff recruitment, our medical staff development. It's all about, again, once you have these access points, how do you bring the services to the people? And then best people and culture, it's the medical staff, it's recruitment intention, it's continuous education and training, educational alliances, how do you grow your own, and organizational alignment so that people understand where they fit with policies, and there's consistency in communication amongst all of our 644 employees. Under operational excellence, we include patient and employee safety, clinical excellence, continuous process improvement, financial resilience, advancing systems and technology, and then risk mitigation. And then lastly, under fabric of community, we have initiatives that focus on promoting healthy lifestyles, public and private partnerships, participation in meaningful events, and then we obviously provide donations and service projects to the community. So we wanted a one-page framework so people can see, all right, this is the big picture, this is the areas that we work on a daily basis, and then the question becomes, well, as an employee, how do I plug into that? What's my role with this? And so really what this year has been about, and the work that the admin team has been coordinating, is cascading down these pillars, these strategic initiatives, into goals or ideas that teams can connect to. You can have a strategic plan, you can put it in a binder, you can communicate it, you can talk about it, but if it's not actionable by every single person in the organization, there's not that connectedness and that stickiness that needs to exist. So this one page is the starting point to allow people to say, okay, well, what are all the things that we're working on? But the next slides are really where I want to spend the majority of the time educating our staff and the board, and that is getting to how do I connect to these strategies. So by pillar, let me go to the next slide here. Oh, before I get into there, I am going to touch specifically on service line growth. So I mentioned strong regional brand and services provided, and then a focused development, expansion, and sustainability of services. Because there is currently a discussion about, well, why do we have a building in Alpine? Why do we have a presence in Kemmer? Why do we have a presence in Bridger Valley? Why do we have a presence in Evanston? Years and years ago, this board and this organization went that direction. And, we've been in Bridger Valley since what year, Mike?
2019.
Was it 2019?
Yes, been in Kemmer since 2013. Evanston about the same time, 2013.
So many years ago, the organization made the decision to say we needed to go beyond the valley. I don't think people understand why. And so I want to spend just a few moments explaining the why of what I think. I wasn't here when those decisions were made, but I want to make sure that it's on the record and people understand the why going forward of all these locations. Mr. Chair.
Question. And Mike helped me with the date. So back in Steve Perry's day, the board and he, I guess, or the board of the administration at that time, decided that we needed to have surgery. And so we started having orthopedics here. Before that, I think we were mostly under IHC, and shortly after that, we were mostly a family clinic. Dr. Kurt was probably here in those days too. I'm not trying to date you, Dr. Kirk, but you and I were both here about the same time. But anyway, what do you remember of that? And that, I think that leads into this discussion of outside clinics also.
Mr. Chair, if I may, I think I misspoke on those dates. Actually, we started doing outreach to Kimmer at the same time we developed a relationship with Dr. Goebel.
Right.
That would have been about 2009. We started going to Kimmer with Dr. Talarico when he came here. And then almost at the same time, we started going to Evanston at that same time. So Steve Perry was the CEO then, Ken Bruff the CFO. And then subsequent to that, we began to, when Dr. Linford arrived on scene in 2012, we almost immediately started visiting the urgent care in Bridger Valley, which was owned by Dr. Goebel. Dr. Linford started a practice in Bridger Valley. It wasn't until 2019 that we took over the urgent care and purchased that urgent care from Dr. Goebel in 2019. So that's where my 2019 date came from. But over time, from 2009 to 2013, our orthopedic program in Kimmer and Evanston really generated a lot of traction because of Dr. Goebel's work down there and his relationships with providers and clinics down there. And that's when Dr. Talarico started practicing down there too.
So the board took over IHC in 99, 2000-ish?
Yes,
Correct?
the contract with Intermountain ended on September 1st, 1999. Was when Intermountain left here and we became an independent hospital.
So about 9 years before we started thinking about surgery. Oh, we're probably thinking about it ahead of time. I wasn't involved back in those days, but
Mr.
so
Chair,
that's how long it's been.
Yeah, I know we had some
Involved.
visiting providers coming prior to that. I know a couple of general surgeons came from Jackson down here. Is that correct, Dr. Kirk?
Yeah, I can,
Please,
if you want me to.
you know a lot more of the detail about that than I do.
I was just trying to get a little historical context of why we started going out to clinics. And I also think, besides the ones you mentioned, we were also, around Linford's time, we were in Logan for a time.
That's correct. In 2015,
And again, that was because
we
of Marlon.
purchased a building in Logan and started doing orthopedic clinic in Logan.
Okay.
And as well as in Brigham City. When we hired Dr. Stuckey, he started doing clinic in Brigham City as well.
Would you mind if Dr. Kirk gives us a little history fill in too?
Your meeting.
It's your education.
Your meeting.
Dr. Kirk, you want to fill in any blanks?
Dr. Kirk, Chief Medical Officer, thank you, Mr. Chairman. When I got here, we had a visiting orthopedic doctor, Forbes, a couple of times a month. Dr. Fleck provided urology services and general surgery about once a week. When we took over from IHC, the first place that Steve Perry wanted to go was orthopedics. He also felt like we should look at hiring an obstetrician at that time, so that was a long process. Dr. Cobbs was our first orthopedic physician, full-time orthopedic physician, and I can't remember how long he practiced, but it was only here in the Valley. I don't even know if he traveled down to Alpine, to be honest with you. So over time, Dr. Fleck or Dr. Lowe started coming to do urology services as well. The next move was Dr. Bender, general surgery, a couple of years after Dr. Cobbs. And then we invited Dr. Brent Clyde, neurosurgeon, to start doing neck and back surgeries I think it was a couple of years after Linda got here. Dr. Stock had been providing surgical services well before my time. So, Dr. Cobbs left, Dr. Calorico took over, and that's when the orthopedic program started mushrooming quite a bit. So.
Thanks for the background.
Thank you.
I thought that might be helpful.
It really is, and it provides some context to the, people want services, right? And so they have two choices. They can either go somewhere else for those services, or we can bring the physicians to the area, or you bring the services to the people. And so that decision, the organization embarked on that decision decades ago. And certainly it has been accelerated with different leaders and different board members. But we are where we are, and so I want to also just talk about, again, going back to the why. Once you decide to go down this road of having various physicians come, how do you make that sustainable? And what it comes down to, it always starts with populations. Do you have enough people to support any given physician in any given specialty? So we did some easy research, and there's your current population. In North Lincoln County, where our district is located, we have 15,000 people. Now that can fluctuate up during the summertime with snowbirds. In South Lincoln, not as many, 5,000. We have locations in each of these counties where we're having our physicians go with the airplane, with driving, and those are the populations of those counties. So if you total them up, you're looking at about 90,000 people. Now, we don't take care of all 90,000, but it's important to understand that with rural healthcare, wanting to provide healthcare services, how do you, one, financially support and clinically support the recruitment of physicians and have it sustainable long-term? In the past, physicians can come, visit, and then their practices leave. So it works for a little time, but there's too much of a revolving door when you have people that are just coming in every once in a while. Something happens in their lives, something happens with the sponsoring organization of that physician, and they say, hey, yeah, we had him coming up or her coming up a couple days a month, we can no longer do that. And then the patients are back to having to travel for that particular type of care. So our organization has to make a decision about how do you not have that yin and yang of patient care. And it's good while it's there, but once it's gone, boy, it can really disrupt how people feel about the consistency of their care. So want to make sure those numbers are on the record, 91,000. Now, I want to read I want to give the board and the community an understanding of what is the population base to just support one specialist. Okay, so based off of the AMC and HRSA, those are the sources. This is the existing recommendations to support one orthopedic surgeon, one cardiologist, one general surgeon, one OBGYN, one otolaryngologist or ENT. And you can see that you could just have one general surgeon here in the Valley. You could have one OBGYN, but you probably couldn't support just in the Valley an orthopedic surgeon or a cardiologist or otolaryngologist. Now, some may argue, well, let's just get that one. All we need is that one. Then you have to ask yourself, how long can one general surgeon take all the call, serve all the patients, all the demands of patient care by him or herself? And the answer is not very long.
Dr. Perks.
Okay. The Dr. Perks was family practice, right?
Yeah, he was.
Yes.
He wasn't a surgeon.
And
Well, that's true. He did do some
He took my
surgery.
appendix out, so.
He did a lot of things, that's
I'm
right.
pretty sure.
all right, well, he was full scale family practice. Let's just
Yes, he
say that.
was.
Okay, and it does, so
That's the word.
let's just pause right there. It does highlight how important primary care is to rural medicine, right? So the primary care base is filling in the gaps where if you don't have these specialists, well, there's some things that a primary care physician is actually doing. Are they delivering babies? Yes. Are they doing ear, nose, and throat procedures? Probably. Are they doing an appendix? Sounds like the answer is yes, right? In rural medicine, you have to do it that way. You go outside of rural medicine, and if you had a family practice doctor doing an appendectomy, help me out, gentlemen, how would that be viewed? They probably wouldn't even have privileges to do that.
I imagine it happens somewhere in the country.
But in an urban setting,
Oh, goodness, no.
yeah, in a rural setting, it can happen. But I'm saying,
Right.
Oh, just urban? No.
yeah, no, okay, so in an urban setting, it's not even, it doesn't even register in people's minds. So you need family practice, you need primary care. It's a foundation to rural medicine. The question that was asked and answered a long time ago is, we need specialists. Whether you like it or don't like it, that's what the decision was made by this organization. Okay? So now that you have 2 orthopedic surgeons, 1 orthopedic spine surgeon, these are conversations I have with the medical staff all the time, is what do you need in order for you to feel like you have a sustainable practice? And this is where we make the investment into our physicians and their staffs, is if you don't take care of the medical staff, you don't have a hospital. You don't have good patient care. And so most of our energy and effort is to figure out how do we make this work. And we have to get creative. And so I asked Dr. Linford and Dr. Stuckey to give me their perspective. The communities, we love having these orthopedic surgeons here. But on one hand, we want you. On the other hand, why aren't you guys just staying in Star Valley proper? Why are you going outside? And so those are 2 conflicting statements. So here's Dr. Linford and Dr. Stuckey, and I think it's very important to read this. Dear North Lincoln Hospital District Board of Directors, we would like to thank you for the time and efforts you have invested into Star Valley Health. We feel it a privilege that comes with a great responsibility to take care of orthopedic needs of our community and appreciate your support. Recent developments have led to discussions regarding clinics and services that are being offered outside of our hospital district. There are several reasons that we feel that these clinics are critical to Star Valley Health and Mountain West Orthopedics. 1, a population of 10,000, he puts down a range of 7,000 to 15,000. These sources are actually saying it's 15,000 to 20,000. Is a suggested number of people to support an individual orthopedic surgeon. To support 2 busy surgeons, we need to look outside our area to help supplement our population. We think that this is important because certain minimum volumes of any surgery result in improved outcomes. For example, it is suggested that a surgeon should perform at least 20 total hip, or 70 total knee surgeries a year to remain proficient and improve outcomes. Our outside clinics are critical to reach these thresholds. Prior to the development of these clinics, the maximum number of total knees performed in a year at Star Valley Health was 52. Number 2, access to subspecialty training and expertise. Currently, we're able to complement each other in our practices. Orthopedics has become so specialized in the last 15 to 20 years that it is unreasonable to expect any given surgeon to be an expert in so many different cases. Instead of compromising patient care or sending patients outside our system, we feel fortunate to be able to refer to someone we know and trust. In the near future, we hope to grow Mountain West Orthopedics in order to offer further specialized care close to home. But without these additional clinics, the patient volume simply isn't available. Number 3, partnership. Having colleagues immediately available to assist in complex surgeries, review difficult cases, and support each other is critical. Number 4, burnout and retention. Our population supports 1 to maybe 1.5 orthopedic surgeons. Expecting a single surgeon to cover all the call and patient needs within the valley isn't sustainable. Number 5, financial well-being of the institution. A quick survey of other hospitals in Southwest Wyoming shows the importance that specialty care plays and the additional revenue provided through the care of these patients from outside the district. Number 6, we would suggest that these same principles apply to other specialties throughout the hospital. As a CEO of Star Valley Health, having run various sizes of hospitals, the uniqueness of Star Valley Health depends on the success of each medical practice. When I came here 4.5 years ago, I knew that there was, that this strategy had already been decided, but it certainly hadn't been maximized. And there was a way to take that strategy and push it forward. And we've done that. Over the last 4.5 years, we have recruited over almost 30 new providers and their supporting staff to serve these various areas. Now, some people may say, well, that's encroaching on Evanston or Kemmer. I would counter that question with, who else is doing it? Who in the state, in this part of the state, is doing it? And if we don't do it, somebody else will. Well, maybe not. We have yet to see some of the bigger systems say, hey, we're going to go into Western Wyoming. I would think that at some point in time where the population becomes big enough that will become part of their strategy. Like was mentioned in San Antonio, Intermountain Healthcare can see their strategy from space. And these bigger systems, they are multi-state. They're now in Intermountain's in Montana. They're in Nevada. They're now in Colorado. And I'm telling from my crystal ball, there will come a time when Intermountain or some other hospital system will contemplate Wyoming. So you have to ask yourself, if you want to stay independent and if you want to be relevant, what do you need to do now? And that's all we have been working on for the last 4.5 years. So that is the why, especially when it comes to service line growth. If the board and the community say, hospital, back off. We're just going to shrink and we just want to take care of the valley, that is a totally different strategy. And it's something that would require some pretty amazing minds to pull off. if you're trying to deliver the type of care that you want to deliver. Yes.
Question then. So let's say it does go there. It would seem to me that then we'd have visiting specialists and they would be taking us back to their home base for surgeries and things. I mean, if IHC was to come in and that's kind of what was happening in the beginning, right, Mike? I think, is we were a first aid station and anything major was either shipped out or they went by themselves on down to IHC, which was usually Northeast Utah, right? And so if that would be the commonality is if we're just taking care of basic needs, then all these other service lines that we've brought in, starting with orthopedics, we'd be traveling a lot more as patients.
And that's a choice, you know,
But that's the option.
But that's the
right?
option, and it goes, and again, there's various reasons why people make decisions in healthcare. It could be price, it could be, it could be convenience, it could be a combination of both. It could be quality of care. If you want high quality care in this valley and in Western Wyoming, you need top-notch doctors that know that they're supported and know that they have the resources to deliver their A game every single day. This is a tough business every single day for these physicians.
So one other question then is, so the other one regionally is St. John's.
Mhm.
It's only, what is it, 75 miles up to Jackson? They have many of these service lines, if not all of them. And they have tentacles that come down into the Star Valley already and have for a number of years. Isn't that an option?
It is, but I would say that St. John's is losing $10 million. You know, I think that they have, what I don't know specifically their strategy. I know that they bought land in Alpine, you know, again, before I arrived.
Never used it.
But what did it signal? Right? They've had some presence in Sublette County. They're trying to figure out how to be, they want to be independent and they want to stay relevant, just like we do. So every organization is trying to figure out, well, if we're going to stay independent, by golly, then if that is the decision, what do you have to do in order to do that? So, let me, just for the sake of time, let me move on. Now, then you get into, and again, the board members have this, but let me just show what each of these pillars look like. This is how we're going to connect this year to each of our employees. We want to give them an idea of, all right, here's the framework of the strategy. Here's why we're doing it. Here is the strategy for loyal patients. Deliver a seamless and exceptional patient experience, ensuring that patients are eager to return to their healthcare needs and recommend our services to others. We want a couple of goals. We have multiple goals, but here's two examples. Increase the rate of return on existing surveys from 11.8% to 15%. The more feedback that we get from our patients, the more that we can improve our processes to support this strategy. We've got to do a better job at getting the return rate for, you know, I think people in healthcare are surveyed fatigued. But the only way that we can get that feedback is not anecdotal. It's a collective on specific questions. And then, based off of the board's input, implement effective patient surveys surrounding the patient billing experience. We cannot, with our existing survey tools, pull this off. Here's why. Billing is not settled until 30 to 90 days after they exit our doors of our facility. So it's an experience that is long after the fact, and we have got to figure out a different way of asking questions. Right now, it's not on the survey, there's no billing questions, but if we're going to really demonstrate that we're improving our billing experience and that revenue cycle experience, we've got to have a way of measuring, not from, all the way from when they register to when they make their final payment. And we don't have that capability in place. So we're listening to the community, we're listening to the board members. We're going to put that in place as a goal for 2026. Go ahead.
Anybody else have any other questions? I seem to be asking. My question was on the increase the rate of return on this 2000, and this is one of the goals, now I understand, right? This isn't all the goals that we have.
Those are just two examples.
Okay, but on this particular one, the rate of return of existing service. So right now, we only get 11.8% return to us that we send out. Is that what that's saying? And we want to get to 15? Whoever knows the answer to that can answer.
Yeah, that's correct.
Okay.
From all of, that's including the clinic, the hospital, surgery, all of our surveys that we send out, we're averaging 11.8 return right now.
And so is 15 a good goal or is 20%? I mean, obviously higher is better, but.
Well, 100%. We could say 100%, right?
I understand.
With setting goals, you want the trick with setting goals is you obviously want to improve, but you don't want to discourage.
Correct.
And so it's a journey. Are we undershooting 15%? I have no idea. But if we got to 15%, then the next year 20%. Or if we make a goal of 15%, we get to 25, fantastic. The purpose of goals is to just make it visible and make it a priority and measure against it. And so there's hundreds and hundreds of goals that we have within the organization, but this is something that we felt like we could share with the board, like, hey, these are the two things that if we were to, as examples, that if we were to improve, we would be moving our strategic initiatives in the direction of accomplishing our objective, according to our strategic framework.
So we have a ton of goals under each of these pillars, or is there just a few that we're focused on, or?
So let me get to that.
Okay.
So now, so you have a strategy, there's the supporting strategies. Boost survey participation by framing it as a way to patients to shape their care, using feedback to refine services and demonstrate responsiveness. Develop clear survey questions focusing on key aspects of the billing experience. We can put goals under each of these supporting strategies. Use data analytics to identify trends and pain points in the billing process and implement process improvements based on survey feedbacks. So there are goals, there are sub-goals, there are sub-goals, and really it's about connecting all of those goals to your staff, day in and day out. So the next slide is, how does it connect with the staff? These are the questions that are going to be going to each team and each staff member as we set up 2026, fiscal year 2026, so that they can make personal goals or their team can make goals on helping move this strategy forward.
So we haven't gotten their responses yet.
Not yet.
Okay.
So we're gonna recommend that you approve this this strategy for 2026 for the board. That then gives us the green light to say, all right, let's go to work. Now, I'm not going to go through every single pillar, but every single pillar has this same format. This will all be sent out to each member of the staff and the medical staff, and they will be talking about this in follow-up meetings so that we can then articulate those goals, put them down, and then measure against them.
So can I ask some things on the other ones you're not going to talk about?
Yeah, no, if you want to spend some time on any other pillar, let's do it.
I just want to understand some of the goals under operational excellence. Increase the number of reported good catches. What's a good catch? by 100% the next year?
Yeah, so a good catch is anywhere in our processes that could have potentially caused harm to a patient, but was stopped before it caused harm. So an example is a nurse goes to give a medication, she goes to the computer, scans the patient's band, scans the medication, and realizes it's the wrong medication. That would be a good catch.
You ask yourself, why is that important? It creates a culture of, one, speaking up, and two, having the situational awareness of what could impact the safety of our patients. And so all of these, some people may say, well, that kind of sounds a little bit cheesy, a good catch and increasing it 100%. But it's not cheesy when you're talking about people that feel very, very responsible for a life of a patient. And then financially, the malpractice insurance associated with that. Then the stress that is given by having to go through a malpractice case. What most people don't realize are all the dots that are connected with the decisions that we make and the downstream impact and the cause and effect of small goals that are worked on by staff members, and how the tentacles of that touch so many other aspects of the business.
So my other question, and I see it under supporting strategies now, is revenue cycle goals. I think that's it isn't one of our focuses, and I think it is. It definitely needs to be over at least the next year. And I gather that second one, implementing an integrated revenue cycle, will probably answer that question. That's a strategy.
Yeah. So if
To
you
accomplish the 80 days cash on hand or something, or?
Yeah, exactly. So if you look at the strategy, build financial resilience that drives sustainability
Right.
and operational excellence. So cash, right now, the organization, well, what is the area of focus? Well, we want to increase our reserves, not just because there's a bank covenant, because it's good practice, it's good management, right? And so what's the supporting strategy behind that? What's the overall strategy? And then you turn to the staff connection. What can your department do to improve the culture surrounding safety? Okay, that's more of safety on operational excellence. What training or process improvement can you introduce to help your team work more efficiently with existing resources? Most staff can impact cash going out. Days cash on hand is not just collecting all this cash, it is also managing expending resources. So if people understand that, hey, we want to stay independent, here's your why, you have a role in that, what is my role? I need to do this specifically, here's the goal associated with that. But we don't want to give them a blank page. We want to give them a connection. It's called catch ball. You give them direction from the top, but they provide the details and it's their goal, and you kind of meet in the middle of agreeing on that goal. If we were to just say, this is the directive, you're going to do this, you lose the engagement, you lose the possibility of them owning their renters versus owners. So that's why we're going through this process.
So in your staff connections, I don't see many questions about revenue side.
Well,
So hopefully these are just a sample.
again, we have, obviously, with the majority of our staff, it is clinical related, right? And if we look at the revenue cycle team, it's not clinically related. There's going to be all sorts of different questions posed to them so they can come up with specific goals, yeah.
But the director leads, Mr. Chair,
Yes, Abby.
the director leads the conversation on what they think they can do. They present them to you, and then you decide which ones make sense to achieve.
Yeah, no, so what will happen is the director and the managers will meet with their teams and they'll say, all right, here are some questions that we need to think about. What are the goals that we feel can impact this overall goal. And then they make that goal, we take a look at it and say, we totally get it. It may not be directly related to this particular goal, but for that particular department, heck yeah. It's something that they can do, they want to do, they're the ones that came up with it, and they're willing to measure against it. Did that answer your question?
Mhm. Yeah.
So back on loyal patients, I had another question I was thinking of. And maybe you've already kind of answered this. If we don't have outside clinics, what departments can we really afford? My understanding in the years I've been here is that most of our areas are, many, like family physicians, are feeders to the hospital. Care center, as far as I know, it doesn't even break even. Urgent care, EMS, and ER rooms, I don't think they even break even. Radiology and lab, I've understood that's one that could and actually brings dollars in. But the other, I mean, general surgery, most surgeries probably do, especially elective. OB, cardiology, ENT, hearing, I was just trying to think of the ones we have. I mean, if we went back to this, what we heard a little bit from the community is let's just offer services here locally. I'm not sure in my thinking that we would be able to sustain it with the tax mills that we receive. The 2 million, I'm not sure that would take care of the losses we have. I mean, it barely takes care, it doesn't take care of the EMS right now,
That's right.
let alone the other ones at the care center and other clinics. So, that was one of the things that, and it continues to make sense to me that we provide, and I think that's why we've done this. Brought in additional surgeons and surgeries and cardiology and ENT, all these providers we've invested in, is so that we can do more here locally and don't have to have our citizens. And it, to me, and I've said this before, and I haven't found anything different, is we're gonna save money as patients because I can do it here locally and I don't have to travel to Salt Lake or Idaho Falls or wherever it might be.
Well, let's just take.
For certain things.
Yeah, okay, so what you're talking about is operational excellence. Every
Okay.
hospital has in its portfolio of services things that are, from a pure financial standpoint, they are positive, break even, or negative. So every organization has to decide, do you want to have that service? Because if we're losing money on any given service, is that part of our mission? Is that part of why we're here? Nursing home, let's just take nursing home. We are having constant conversations about how to make that sustainable. We know that any loss for any service that we're providing, we can't, the joke is, well, just do more surgeries to pay for everything. Well, we can't do that, right? So you have to take each business unit and say, how do you minimize the loss on that? If the board and the community say, we want that service. Now, we can make decisions about labor reduction, but what are the consequences of doing labor reduction for any given service? We just experienced it with EMS, right? True. So everybody, I wouldn't say everybody, most people want the services. If you were to do a survey in the community saying, hey, should we keep our nursing home open or should we close it? I can already tell you what the response is going to be from the community. Keep it open. Okay, you want us to keep it open. Here's what we're going to have to do in order to keep it open. Well, we don't want you to do that. Well, you just told us you want the service and you want us to keep it open, but we can't, you also want to handcuff us and say, you can't do this, you can't do this, you can't do this. And so, you know, I'll just tell you, Tori's done a fantastic job of even just looking at the billing and revenue. And she and her team care so much about the care center and those people, and they know of the pressures that nursing homes have, and they know that this community needs that nursing home. With her analysis just recently of billing, we're going to be able to find an additional $500,000 to support that service line. That is operational excellence, is you have to isolate it and say, how can you improve it if you want to stay in that business? Now, are we having these same discussions with EMS? Absolutely. You've been part of those discussions with each of the community leaders. Is it sustainable right now? No. But if we don't get involved as a hospital, what happens to EMS? We want it, but nobody wants to pay for it. So I recognize that the community has differing opinions about what services and where, but I frankly don't think that most of the community understand all the dynamics and financial resources to deliver those services on a sustainable pathway. And that really is why we're paid what we're paid, is to figure out that complexity. And frankly, you know, for what we're doing and what we're pulling off in this type of environment, we're doing a freaking dang good job. My team and the medical staff, we are getting very creative on how to pull off what we need to pull off. Now, if we were a for-profit hospital and all it was to increase shareholder value, would we have EMS? Would we have a nursing home? Would we have, you already know the answer to this question. Evanston is a for-profit hospital. Do they have OB?
It's dropped.
Okay? Every community has to decide what they want, but they also have to ask the question, how they're going to pay for it? How they're going to sustain it? Does that mean buying an airplane so you can take your specialists so that you can increase surgeries? We made that decision. And we don't take it lightly. We recognize that there's going to be all sorts of optics on our decisions. But frankly, those optics are pretty short-sighted with everything that goes into account to create a sustainable model for all these different services. And I appreciate the input that people have. I respect it. I will always value it. But I will challenge anybody to say, you want that. I'm open to your suggestions of what is the solution to make it sustainable. And not a lot of people can articulate how to actually do it.
That's all the problem.
So this is why it's important, is we want everybody in the community, the board, this strategy, this ship sailed a long time ago. And you know, during my tenure as a CEO, I'm taking this strategy and we put it on steroids. And people can agree or disagree with it, but there was no going back, you know, before my tenure, and I don't think there's going back, you know, after my tenure. I think that this organization, if you want to have these services and accessibility to this talent pool of physicians, you pick up one end of the stick, you got to pick up the other, and that's what we're trying to figure out. So,
One question.
Yeah, go ahead,
Service line,
please.
says increase total outpatient visit by 2%. And my note was seems kind of low. Is it realistic? Is this all service lines or, no, it's 8 outpatient visits, so that's where everything's growing to is outpatient, not inpatient. That's orthopedics,
So,
I assume, majority, maybe some general, some cardiology,
no, you'll,
ENT, pain, all that.
yeah, so when you combine physical therapy, when you combine primary care clinic visits, right now, we are projected to do probably 75,000. A little over 75. 75. We made a goal.
Procedure, what, 75,000 what?
Outpatient visits,
Oh, okay,
outpatient encounters,
okay.
that we bill for, right?
Yeah.
So why, so this is the connection. You create the strategy, but it needs to be tied to your budget. If you accomplish your strategy, you should see financial results. In order for us to reach the net revenue we need to produce cash for capital investment, to give increases to payroll, to do everything that we want to do in this upcoming fiscal year, we need that goal to be accomplished. We set a goal last year of 72,000.
So what, we increased 3,000?
It was a 3% growth. We exceeded that. So you can, why 2%? It's directly tied to the operational budget.
Okay, well, and the reason I'm asking these questions, because the next item on our agenda is, I assume, approving the strategic plan. And I've never been a rubber stamp guy, so
That's all right.
I want to make sure
No,
that
that's all right.
we understand what it is we're approving.
I think the big takeaway that if I'm a board member is I've been part of organizations where you come up with a strategy, but where organizations really struggle is, and we've struggled with this in the past, is how do you connect every staff member to that strategic plan?
Well, and I agree with you that you've got to start at the bottom. They've got to buy into it, or, I mean, it's just like I always thought with providers. I mean, if they're not on the same page as the board, we're just knocking our head against the concrete wall for a long time, and we're not going to get anywhere. Hopefully, we're all aligned. So last year, you said we increased from 72 to 75?
We projected at the end of this month, we set a goal based off of our operating plan to hit 72. We're going to
Well, to hit 70.
hit 72. We're going to exceed that by 3,000 visits.
We'll be at 75? And what did we start with? What was how much growth did we have last year then, I guess is what I'm asking.
So I think last fiscal 24,
Yes, we're gonna be at 75 in fiscal 25. And our goal is 2% of that.
it was at
26.
I think it was a 3% growth. So whatever that number was before that.
So just the 3,000 over the 72 is a 4% growth.
Yes, so
So I still ask the question, is 2 a reasonable number?
absolutely.
Why we achieved 4 last year?
Well, so
At least.
so that was based off of how many physicians we're bringing on.
Right.
This year, not as many physicians, right? So
Are they all at max now?
no,
Okay.
no. There has to be a rationale of what is going to drive that growth. One, is it going to be population?
Okay.
Okay. 2, is it going to be more access points? 3, is it going to be that a physician is ramping up their practice and they still have opportunity? Are you do you have more offerings of service lines? This upcoming year is going to be more operational focused than just access points. So 3%, we made a goal last year, we're going to exceed it. 2% is tied directly to the operational budget. We think it's very reasonable.
Okay,
And that's 2% on top of 75,000.
that's only 1,500, isn't it? Did I do my math wrong?
Well, that's the number
So
that,
that's half as much as we did last year, is my point.
3% is like 22.
3% of
On
72?
75,000.
Marlo, I think it would take a long time to dissect and have a discussion about what the right number is.
Well, then what is it you want from us to approve?
Well, we're making the recommendation. Here's why we're making the
And I want to
recommendation.
know, yeah.
And I just explained. We put the operational budget together. When we look at volume increases just on outpatient visits, we're gonna need to get to 2% to get to our net revenue number.
Don't disagree. Okay, I've heard that, but what I'm saying is that's less than we accomplished last year. So every year we're gonna do less?
No.
So I'm trying to get convinced that
It's the same,
two is anywhere clear.
it's the same methodology we used last year. We presented an operational budget. We came up with 3%. Did we exceed it? Yes, fantastic. Are we saying that it needs to be 3 or 4% every single year because we've exceeded it the previous year? Absolutely not. Because of the circumstances, because of what we feel confident, we're making a recommendation to the board. Now, you can either trust it or not, but we could.
Well, but I can verify it.
You can verify.
That's what a board member does, I think.
And what I'm saying is, I think it needs to happen probably in a finance committee meeting
So,
to have that discussion.
okay,
But
then it may be hard for me to approve the strategic plan.
So
I mean-
change to 3%, then we'll be fine.
What's that? I'm just asking the questions that come to mind. Okay. I've heard your answer. Local, one of the things I heard from the community was under service line growth, telehealth positions. Now, the two, I read somewhere in our reports here that we're growing, things for our physicians to have telehealth. NICU or something, and, what was the other one? Rheumatology, thank you. But I think these folks were asking, and I didn't hear from every community member, I heard from one or two, they like telehealth to family physicians. They can call up a nurse, get some immediate reaction because they have a question and they can't get into the see the doctor. We even got that on our radar. Is it expected throughout the community, or I don't have a statistical database here, pretty small.
yeah, right, no, it's a valid question. Right now, with our rural nature, telehealth has only been focused on those services that would be almost impossible to recruit here or provide here and sustain it. Right now, primary care, you can get into a primary care and see them face to face.
In 2 months. Yeah,
No,
well, it's been
it depends on the
my
doctor.
family's experience.
Well, it depends on the physician,
I don't disagree with that.
right?
Yeah.
So there are some physicians that have really established practices. They have a very large patient base. It is going to be a little bit more difficult to see them in a timely manner. But we have not, to answer your question directly, we have not introduced tele-primary care for those existing practices. Now, should we? We've never had the discussion.
One of the items I heard, when you say that there's other doctors you can get into, how many people do you convince that they want to see another doctor? Most of them are pretty well set in their ways. When I talk to them, they say, well, it's either this one or that one. I don't really like that one. And they may have availability, but they don't want to go see him. So how do you handle that?
You've got to just explain what their options are. And so let me give you an example. The mother of my son-in-law lives in Ohio, outside of Dayton. And her primary care physician left. And her next available opportunity to see a primary care provider, not a physician, but a mid-level provider, is in 1 year. And that mid-level provider hardly speaks English. So I appreciate the frame of reference that people, there's expectations that people have. And when we don't meet those expectations, it disappoints. And they will say, I can't get into a primary care position. It's all relative. And now there's folks that would say, well, you know what? We're not Ohio. We are Afton, Wyoming.
I was gonna say that.
Right? So I get it. I get it. Now, the question is, we can recruit all the primary care physicians we want, but if they want to see Dr. Morgan, too bad.
Understand. When they're in pain, it seems like it's a different decision. They need to see their doctor or have a call or do something. And so I don't know whether telehealth would be an answer to that. It was big there for a while, and even in the bigger communities, I'm not sure if it's really taken off that much down in Utah. And that most doctors want to see you face to face, I think, because it's hard to prescribe or diagnose is a better word over a screen.
Yeah. So
I would just bring that up as a thought.
I would say that, when a primary care physician is not available, we have exceptional urgent care that they can get into. If it truly is an emergency, obviously, we've now created another access point for emergency care. But to your point, we have not had a discussion about how telehealth would impact primary care and whether or not there is even the capacity for that. And that could take.
Well, yeah, I mean, if they're already booked for 2 months, I don't know what time they're gonna do telehealth.
Right.
But is there a mid-level or a nurse practice, an urgent care?
We have
Do
explored.
they stand around a little bit during the day, or are they just constantly busy at urgent care or ER?
So if you were to analyze, let's just take Dr. Morgan's practice, he is what percentile rank with RVUs for him?
Last time we looked, I couldn't tell because it's over the 90th percentile, and so the median. Last time I looked, the median was like 5,000 RVUs, and last time I looked for his is about 10,000 RVUs.
That's a month a day.
Per year. Per year. Yes, he's like.
He's Dr. Perks II. I understand that. He sees 50 a day or whatever, which most doctors in my communication with them, they go, you gotta be kidding me. But he chooses to do that. And there are people that do that. There are others that don't. So the point you were making with Dr. Morgan.
Well, I'm just saying you could talk about telehealth with Dr. Morgan, but when is he?
No, I agree.
So there are, in healthcare, there are constraints. And those constraints, they clash with people's expectations. And anytime that clash happens, there's dissatisfaction. And there's not enough primary care, but what really is the issue is he's a specific physician I want to see, but I can't see him in a timely manner. So you need to fix that. And the answer is?
There is no fix to that, unless they choose to do something. But the telehealth side, I don't think it could be Dr. Morgan, but it could be other physicians that could answer questions on a basic.
But again, I'm going to go back to what you originally said. That's not the doctor that I want to see.
Well, that may be the choice. I don't
And
disagree.
so then I'll go back to what I said, is you have to let people know what their choices are.
Okay, on your supporting strategies for service line growth. Strengthen relationships with referring physicians to ensure the patients are aware of and refer to your outpatient services. Or is that our outpatient services or your?
So we could fix it to our.
Well, I assume your is that the same as ours? I was thinking that was somebody
Yeah.
elsewhere. Okay. And along with that, then my question was Kemper Diamondville. Where's that in our strategic plan? Are we,
So it's already established. So strategy is something that is brand, something that's probably new, hasn't been operationalized.
okay,
Kemper is already an established access point. Right?
okay, I'll take that.
Okay? What's happened is the change of those operations. That's really the discussion. So you could say that it's, the strategy is having a location in Kemmer. Has that been accomplished? Yes. We could lose it if we don't change the way that we operate our location there. And that is by establishing a different location. So it's in the world of.
So it's not in the strategic plan, it's in operational plan? I
An
mean, there's
operational plan.
Something else?
Yes, an operational plan.
Learning something new every day. Fabric of the community, giving back to the community, you'll decide those events, I guess. I mean, obviously, there's Star Valley Half Marathon that we're involved with. I don't know if the golf is really a community event more than a fundraiser for the foundation. So I guess I'm thinking when you say these volunteer projects, this is more service-oriented projects rather than money-making projects. Would that be correct?
Whether it's our involvement in the food bank, whether it's something, if there's a particular need that we feel like we can plug in, we want to, again, make it visible, talk about it, and make sure that it is an initiative that we're trying to accomplish.
And so somewhere in your strategies or whatever, it will be kind of service-related projects, maybe?
Good. I mean, everything.
I mean, it all could, but you want me to approve this today, and if it's a could, I don't know what I'm approving.
Well, let's just say, let's take the half marathon, for example. Is that a service project?
For the family that started it, yes.
Is it a
For the
service?
community,
Is it a service by individuals that are giving up their time to support
yeah,
something, right?
sure.
So it depends on the, how you want to answer the question of service. I think anything where you give of yourself and your time, people can construe that as service, whether that is at the county fair, at a half marathon, at a parade, at a golf tournament. We want to give our people an opportunity to serve in the community.
Abby?
May I address Dan?
Sure, yeah. Ask any question you want.
I am also about the approval. Marlon, please bring that point up, but just to clarify, we're just approving that we agree that we're not shifting gears and canceling all of the outpatient clinics everywhere and then coming back in-house? Or are we looking at the nitty-gritty details of it? When we say it's approved, do we have any, finance committee could really dissect what that budget piece looks like, what the pillar or quality, really looking at billing department stuff, what are we approving? Because we've had this for the last couple of years. That hasn't really changed, and then what you're looking at and where we need to prioritize has changed. Are you just asking if the board agrees that we're on the right strategic path?
Yes, the strategy is the overall direction. This is why I spent so much time making sure that the board and community members understand, hey, people have questioned our overall direction.
So do we want to maybe, Mr. Chair, just have a general filler on how the board's feeling about general strategic plan?
Yeah, I think as we get into that item, we will.
That one, okay.
And yeah, I think Dan's brought up a good point on the whole direction. Do we need to revisit that, or are we still in
I think
same
that's-
direction?
Yeah, and just
I think that's
clarifying,
one question.
Are that's what we're approving, that's what we're being asked to approve. The general direction of the hospital.
We're
I think we all have
also,
opinions
we're
about the
also
micro
approving,
details.
I think we're approving two things. One, the new question is, do we like the direction we're going overall?
Right.
That's the one that Dan has brought up today, I think, right?
Sure.
And why we're there and that we need to rethink everything if we're not gonna continue that, right?
Sure.
But there's also, and what we did a year ago was to approve a strategic plan, and so I guess I need to be educated as to how much of that plan do we approve as the board? Do
Right.
we approve the budget, we approve the capital budget,
And the overall direction.
and the overall direction? So you're saying all we get to approve is the direction that we're gonna expand growth here by using outpatient clinics?
Well,
That's really the only decision before us.
no. Remember that there's 4 other pillars, right? Is you're also saying, hey, these are, we recognize that you have to have strategies that pertain to patient safety and quality of care. You have to have strategies that pertain to retention of good talent and attraction of talent. You need all of those pillars. Again, they're not mutually exclusive. Don't think of the strategy as just service line growth. It is a pillar. We talk about it a lot, right? But in order for service line growth to happen, you got to have the other 4 pillars. When you take a step back at a 30,000 foot view of the overall, so strategy doesn't change from year to year. We're talking multi-year idea-driven and implementation of strategy. Then the board says, well, I want some details about operations. That's where I think some of the committee discussion can take place. But when you take a step back and say, hey, here's what they're trying to do. They're trying to accomplish these things in this pillar. They're trying to get the employees to understand their role in driving that strategy forward. And is it ultimately helping us accomplish our mission, vision, and is it part of our values? That's what we're asking you to approve. Is that 30,000 foot view?
So then why do we spend any time looking at this?
Because if we as a management team don't somehow articulate a roadmap, an understanding of how this framework fits together, then we're going to be ineffective leaders. We've got to be able to communicate it. So that's why we talked about it.
Yeah, but if all we're deciding is the same thing that was decided 20 years ago, I'm not sure. I mean, we can decide that, but how do we measure anything that you've accomplished? If we're not part of the discussion or the engagement of that's where we ought to be. And I don't know how, I don't certainly want to go into the nitty gritty down into the weeds of this thing, but
Well, I think,
what is it we approve when we approve the strategic plan?
so.
I guess is my question.
Yeah, so I would say as a board member, you've been intimately involved month after month in various subcommittee meetings, trainings, the discussions down in San Antonio. The strategic plan is not just some magical thing that just automatically changes for the organization from year to year. It is a compilation, it's a conglomerate of all of these discussions. And you have to ask yourself, do we need to pivot from that strategy that was established 10, 15 years ago, a year ago? Doesn't matter. What is the overall direction of the organization? And does it need to change? And if in your previous discussions, in your time on the board, you say, oh, we have got to change course. Well, that should have probably happened a long time ago. Because we as administrators are heading down this road. We're trying to make sure that we're aligned with the board in our discussions. And if we're off base, then let's have the discussion. If you feel like, hey, overall, this strategic plan that you have presented and been consistent with over the last several years is the right direction, then I would approve this year's strategic direction.
Not knowing what it is, but yes. Okay. I'm taking up too much time with the discussion. It sounds like you guys are ready to move forward as a board to,
Mr. Chair,
yes.
can I have a second? So I just, you're talking about the details, nitty gritty, and I think the concern is the concern is that we approve something that we don't realize we're approving or this or that, but, a strategic plan is, in my mind is similar to your operational budget, something like that. Yeah, you have some stuff on the budget, but it's a budget. It's not gonna be actual, things are gonna change, things are gonna come up affect along the way. And so the details, I think, have to be left within admin's ability to define as we go. And that's my take on the strategic plan, is it is exactly what Dan was saying, is alluding to, is it is a 30,000-foot view of, hey, this is the model we want to use. We can question the model that was decided from 2007, 9, whenever it was, 2000, whenever, I don't remember all the years exactly, but we can question that and say, hey, you know what, we need to go back and take a step back and actually decide maybe we don't want this growth strategy. But I think that overall, in what we're approving is simply that, hey, this is the model we want. These are they highlighted some key areas that they want to address, and I don't think you're going to have all the nitty gritty details of how they're going to address that, because it's got to be a little flexible during the year as things come up, that type of thing. And so, me personally, on a strategic plan, I'm okay moving forward, knowing that it's basically a general plan that we're going to get more detail as things come up and as things become more pertinent on this or that. I think if we try to get all the details right now, I think that's a really big ask, and it could get into a really big strategic plan, if that makes sense.
Hopefully it is a big strategic plan.
Mr. Chair.
Abby, you had a comment?
CEO goals are presented annually. Typically, there's 5 of them. Do they tend to revolve in your mind around one of each of the pillars?
Yes, so this past year, that's exactly what we did. And they were all pillar centered. And I would say that, does it tie somewhat to the strategic plan? Yeah. But you could come up with, tens of thousands of different goals, whatever is important to an individual. It's just trying to figure out which goal is important for this upcoming year that the CEO and the board feel like, hey, if you were to accomplish that, it would move us a step forward in the right direction.
Follow-up question or comment. The way that I interpret that's in your employment contract. Would you agree? This goal setting situation,
Yep. Mm-hmm.
It indicates, the way I read it, that the board sets the goals. So the concerns that you're having, I think, could be alleviated if we all have our opinion about the strategic plan and first going to proceed with it or not. That's an issue that we're being asked to vote on. And then how that's executed. You're not just getting free reign. You get to pick the pillars, the sub-points, the subtopics, the goals, and all of that matter the most to us as a board from what we've heard in the community or where we think that the hospital needs to go. So it's not just one vote today and then it's like it's out of our hands. To me, I think if we fix that one little thing where we're a little bit more involved in setting goals that we ask them to achieve, then we alleviate the kind of going. Because like we get the heat, like when things don't go like, why are you doing this or that? Like, because it's part of the strategic plan that we agreed on, we're going with it. Certainly, you're gonna ask our opinion later. I think it makes sense to be in other communities. I love the doctors we have, and I understand all of that. From 30,000 feet, that totally makes sense to me. Then the nitty gritty of it, I'm like, I think we could do that better. But all of that's articulated in a way that we can achieve that. It's just, I can see why you're uncomfortable just saying, yeah, we're approving that, but it's the same thing we have approved year to year, and you've had like a decade of approving the path, right? I mean, and then you feel like it's out of your control. I can see both sides of your brain working here, like, if you're gonna say yes to something, then what's the next course of action? I appreciate your questions today.
Are we ready to talk about the strategic plan then? You guys have any other questions on Dan's education?
I like that everything's laid out and it's optional.
Yeah.
Like, there's so much in there that if we get 3 months from now, and like, we don't like that version of it, just because we would hate it today, I think doesn't mean that it's stuck at that. So I think
It's a very good point. You know, I would say, Sean, that on a regular basis, you know, we try to give you updates on where we are with certain goals. And, you know, it could be the CEO goals, it could be goals that are in various departments, and we do that through the subcommittees. It could be other goals that you feel are important to the strategic plan. Again, there's hundreds of different goals that we could talk about.
Yeah.
Right? And it's a collaborative process. And our role and responsibility as a management team is to make sure that there is a plan, and we have this direction, we have goals. You know, you can challenge the goals, you can challenge the direction, and that's your prerogative. But our responsibility is to at least put something on paper.
So what I hear we're really approving is we're not approving the strategic plan, we're approving the direction our organization is going.
That's a strategic plan. It's as simple as that.
I beg to differ. My argument is if it's a strategic plan that you want approved by the board, then I want to know what the plan is.
And that's why I think we should take, to make everybody more comfortable, control of the goals that we set. That's where you have the ability to dictate what leadership does with.
And I'm not sure we ought to be approving strategic plan. I don't know that we need to get down into those details as a board. We need to be, here's the direction.
The reason.
Do we want to be growth? Or do we want to go back to what it was pre-2000? I mean, isn't that our discussion?
Are you talking the difference in the regional versus the one hospital that acted on only with 3 primary care?
Right.
My personal opinion is there's no way in hell you're ever gonna go back to that. Right. And afford what we do, simply put. I mean, it's easy to look at that from where I'm seeing that now. So I don't think there's a real discussion to have there. I think really most importantly, that really colorful table that Dan put up there covers everything in every direction. I mean, billing's in there a lot more, and I think the community's in there a lot more.
Yeah, based on what they've
than
heard,
has been.
right.
Because of this last 3 or 4 months, we realized that, hey, we need to look into that more. Now, do we know that what is in that is exactly what billing needs? Not necessarily, but there's stuff in there that we can, like Abby's saying, say, hey, Dan, let's make this one. Billing is your goal. We're not worried about this other stuff. We're not so worried about this regional growth right now. We're worried about getting our billing buck in there. And that's what this strategic plan or this direction, because to me, they're the same thing, does. It just gives it that all encompassing. And I think that's all we're approving today is, you know what, this covers it all. In a month from now, if we're still worried about billing, we're gonna hang on billing.
Yeah, and
maybe I'm wrong, but that's
how I'm going to. We're being recorded. Like, I think it's an opportunity for each of us to state, like, on record, where we feel like the direction hospital's going. Because a lot of us have heard both sides of the equation. Stick here, stick local, do what you're doing, versus being out in communities. I think that's what we're being asked to look at today. That's my understanding.
So how do you each feel about our direction? I mean, I just heard from you.
Well,
I think you're saying.
It's really funny because before I got here and before I've sat in on 6 or 8 of these meetings and seen what the hospital's doing and got a better understanding for what it is, I just said, stop your growth. Why are my taxes paying for something else? Why are my taxes paying? This was easy for me to say that, but now that I've got here and I see this strategic plan and I'm in on it and I understand it more, it's easy for me to go to the community and say, I understand guys that you want just this local thing. But your $2 million won't support it. The plan that is in place to reach out to these other places to bring the money in is great. And we just, I can go on further, but that's my thing, is really, the regional thing has to be there in order to have the nice things that we have. They really, really do. So if all you're asking is my vote on whether we're regional or some danky little hospital in the middle of Star Valley, no, it's gotta be regional, or you will just be some, Dr. Norton will be there and there'll be a line clear to Alpine where we see him. And I don't want that. I want the specialty doctors here and I want that. So the regional thing makes sense to me. It really is as simple as that airplane. People saw that and they were mad until a 10-minute conversation happened and they understood the convenience and the benefit of that airplane. The whole hospital is built like that airplane is. And we just have to get the community to support and understand that.
Cole, thoughts?
Yeah, I fully support the direction that we're headed. Again, I think that there's details that need to be worked out. I don't think this is the time or place to work those details out. I think that we have identified some, some pressing points that we need to look at, and we'll get more detail at a later point. But I think to go backwards now, I mean, there's just I was gonna say, we're not gonna be able to go backwards. We're not gonna be able to support what we've got here. I think that in general, most everybody wants the services that we are providing as an organization here in the Valley, the convenience of it. And again, sometimes it's just not knowing, that, hey, that service is actually provided because the hospital is taking a loss on it, and they're just doing it because it's the right thing to do. Again, not to get into the weeds on this, but I think that there's a lot of that goes on that, again, we're very fortunate to have what we have here. It doesn't come from retracting and going back to where we were 2009 or before, whenever, I forget the years, but Mike can correct me later. But I think that at this point in time, we've got to, that doesn't mean that we have to blow and go. We sometimes, a growth strategy involves making sure that you're sustainable to achieve that growth, right? I think that's what we've been talking about for the last few months now. Yeah, is making sure that we're sustainable so that we can go ahead and continue that growth pattern. So that's my comments, I guess.
Mindy, comments, thoughts?
Same as what they can. I don't need to add to it, add to the time. I'm of the same opinion. I like the strategy that we're going, and I defend the strategy in the community. I understand optics, like what they see, but unless they listen and hear what's going on, they understand all of it. They don't. Yeah. This made sense to you, so I do agree there are pillars that we need to really focus on more so, but that doesn't mean I want to change the pillar. So.
You're looking for a motion
Yes.
to approve the strategic plan
Yes.
I make a motion to approve this strategic plan
as presented?
And I second that.
So we have a motion by Cole and a second by Abby to approve the strategic plan for fiscal year 2026. Any further discussion? All in favor?
Aye.
Any opposed? Show that it passed unanimously. We'll be on public comment. Chief of Staff, we appreciate you staying around, getting up when you need to. You can take your report now.
Thank you. We are not on a credentialing month, so I thought it would be important, especially in light of some of the discussions that have been had today. I've taken like 5 pages of notes with comments. I won't share those. So do any of you know how big the medical staff is?
624.
Negative.
I don't know.
Medical
Oh,
staff.
well, I don't know.
Do any of you care?
Yes.
Why?
40 odd.
Why?
I'm on credentialing. It's good to know who's working here with us, but I want you guys to be happy. I love the care you're providing for us.
Okay,
We just like numbers.
They're people to me.
that makes sense. Yeah, it's just a number, right? Active staff. Those that are actively participating can participate on communities or on committees, 30. That would be your MDs and DOs, okay? Affiliate staff, that would also include MDs and DOs that aren't here on a full-time basis. So some locums that have come and continue to come back in various capacities and have requested to stay on as affiliate. That number's 30. Allied health, so your advanced practice providers, 28. So the medical staff currently, as of today, is 88. That is where we're at. Dan made a comment about, I've heard this magnet for talent. And I will make this comment. I don't think the hospital staff in general recognizes it, and I'm pretty sure the community doesn't recognize who we have here. They choose to practice here. They don't have to, and they choose to. Standing offers abound for these individuals. So of those 88, of course, the affiliate is 30. They're not always around, but the allied health active staff to a great degree, so 58. So 50 to 60 of us are around on a regular basis. So we every quarter have a medical staff meeting. That is July 17th at 7 a.m. I would invite the board to attend that meeting if available, because I think it's critical you know us. I think it's critical you hear from us. I think it's critical you understand our thoughts. Now, the community's out there and saying stuff and everything, and so in the spirit of equal time, thank you, Dan, we would encourage you always to attend that meeting.
Repeat.
July 17th at 7 a.m. We'd make it earlier if we could, a bunch
Sounds
of us,
good.
but I know somebody that's up, Marlo. So anyway, that has been one of the comments from the medical staff. And, excuse me, here. Yeah, and there's a Zoom link as well. We're happy to provide that to you. We encourage everybody to come together in person. That always isn't, that's not convenient. Sometimes we will have the Bridger Valley individuals here as able for this July 17th meeting. Many of our staff have never met them, don't know who they are. And turning the table, we don't know you necessarily. I'm speaking generally. It's important for us to know you. And so there's some other things in place. And I visited with Marlo about that, and we're going to start rolling that out from a medical staff standpoint.
Excellent.
Okay?
How long is that meeting?
It's an hour. Mr. Chair, we keep our meetings shorter than others do.
You're welcome to have them for 6 hours for equal time.
Than others do. Anyway.
And that's here in this room?
Yes, sir. We're not even going to feed you. Let's not even pretend.
Oh, then why am I coming?
That's a good question. I answered that previously, Mr. Chair. So anyway,
We appreciate that.
that's who we are. Every other month is a credentialing month for us. So that number is a moving, it's always moving. So, but what I want to share with you today is it's critical at this juncture that we get to know each other better. And so going to be effort from our side, and I know you guys will reciprocate, so we appreciate that.
Thank you.
Questions? Thanks, you guys.
Thank you.
Okay, we have financial results, consent agenda and bills against the district. So let's,
Mr. Chairman.
yes, would you like to pull the bills out?
Yes, I have a couple of questions.
I have a couple myself. Anybody else on the, see if I had anything on the. Anybody on the financials? I'm just gonna ask one question, and then let's vote on the consent agenda with, like, pull the bills out. Do we need a motion to pull the bills out? That's the proper way?
That would.
All right, I'll accept the motion to remove items from the consent agenda. Mindy, do you wanna make that motion?
I will make a motion to remove some items to be discussed, bills paid for the district out of the consent agenda.
That's the only item I'm pulling, right?
That's the only thing I have.
Anybody want to second that?
I'll second her motion.
Moved by Mindy, seconded by Abby, that we remove the bills against the district from the consent agenda for further discussion. Any other discussion? All those in favor? Any opposed? Okay, my one question, I guess, was on the statistic page. I'm wondering what we compare this against. I mean, I see all these great statistics, I like statistics. Is there, I know in the other industries, there's peers that you are ranked against because of size, population, something. Maybe some kind of a column that shows where we ought to be. I mean, what are we judged against with our peers? And I was also thinking, Dan, that we could have maybe some education for the board. I'd like to understand what these are telling us, and that maybe Scott could, maybe even next month, have that as the education, unless we have something else planned. Sometime in the near future, I think we've got to have some education on this statistical page. It's a new set of statistics, a little bit more detailed than we've had in the past. And I think in a lot of these, I know some of these abbreviations and I've forgotten others and haven't learned others. And so, Scott, that's what I was thinking. Is that something we can accomplish?
Absolutely, Mr. Chair. Right now, the comparative is to ourselves.
Sure, and I'd like to see the trend.
Yeah, and so there might be some of those statistics that are generally published. But the hard part is we're a critical access hospital, and if we start introducing other hospitals, I don't think most hospitals are getting to this level of statistical analysis.
Probably not.
Okay, and so there's going to be some of these that probably are not public information that we could, but the whole point is for us to make sure that you're able to see the trend and whether or not something's improving or.
Agreed.
Yeah.
I'd love to see the trend,
And
but
then,
I'd also like to see, what am I comparing? I mean, is it good or bad?
Yep.
Is the trend?
Yep.
I don't know whether it's good or bad.
totally. So then the second part of this, your question is, what we'll do is we will create a definition list of each of these statistics. So you know beforehand what you're looking at, and then we can give you an educational session. It could be next month or the following month. It's your prerogative.
Scott?
Mr. Chair,
Yes.
I'll reduce the plan that we will discuss today to be a comparable column by every one of these items.
Oh, so you make the percentages of what we plan to accomplish, then you'd have the trend of the actuals.
Actual to plan.
Actual plan plus maybe some kind of a standard that.
Just a peer comparison.
Peer comparison. That's a good word for
There's
it.
a lot of them that are available, but
That would be helpful, I think, at least for me. I don't know about everybody else.
Mr. Chair,
Cole?
so while we're talking about it, one of the things I'm not a huge fan of comparing the individual month over the previous year's individual month. And I understand that you're gonna have some months differences. I would rather compare it to last month. So like you had fiscal year, May of this year, fiscal year 25, compare it to April fiscal year 2025. And I understand there's gonna be some differences between the months, but I don't know that, you know, I like the fiscal year to date, for the 11 months over on the side. I like comparing that because that goes back. That really tells me all I need to know comparing it to last year. But comparing the individual months, I'd find more information or have it more helpful comparing it to last month. Because then I think you're gonna pick up some, if there are big discrepancies month to month, I think that's where you pick it up versus looking at the same month last year doesn't really tell me a ton, I guess.
If I may.
Scott?
So the way I want to address that, and I talked to Marlo, and I think the finance committee too, is that in addition to kind of our standard here, where if we take month over month and, you know, year to date, is a rolling 12 month, it's regardless of your fiscal year, just rolling 12 month look. So then you can see 12 months. If you want to have 13 months, then you get that prior month last year and the 12 months leading up. So that's how I kind of envision doing it.
That sound good.
So the only thing I see with that is anytime you start doing rolling, or year to date, you know, for the last 11 months, it doesn't allow you to pick up on major discrepancies month over month. Whereas if you compare that last month
You could
to this month,
be right next to each other all the way along.
and that's fine if we just have it. But I just think that it's important to, if we can look at last month and say, oh wait, wow, this is huge discrepancy from the previous month. You know, it may allow us to just catch something that we wouldn't
That'll be on
otherwise
that
catch.
trailing 12 months, where you'll see exactly what it was. You'll see exactly the discrepancy, the change month to month, and 12 months. It's like 13 different columns doing that trend. That makes sense?
Yeah, as I say, yeah, I mean, if we can do that, I just think there's some value to doing that versus.
Well, let's try and see how it works.
Yeah. Maybe see if we can get something that's proposed and we'll look at it.
All right, moving on, bills against the district. Vinnie, you had some questions?
I just had a couple of questions. So it looks like we purchased a new ambulance. Was that on before everything happened? Was that on the capital expenditure? Had we ordered that? Was that on before so we had to pay for it?
Scott?
It was ordered like 16 months ago.
Okay, so we didn't have a choice. We had to pay for it.
What was the second one? Wasn't that, didn't we
Yeah,
wreck
what
one?
was the other
Did we
one?
wreck one?
We wrecked one.
Last
We
winter?
wrecked one down just north of the Narrows.
Okay.
Wasn't our fault, but that was the payment to get it fixed, remounted, everything. We did recoup all the $50,000, which is deductible. Anyway, that was the net that we owed.
So that was to replace that.
We net added out about 120, I think it was, right? Because you got 50,000 from the settlement.
No, we got about 150,000 from the settlement.
That's right, so the $50,000, yeah, $25,000 deductible.
So the Hinman agency, 13,000, I thought he was about 10,000 a month. When did he go up to 13?
We've made an adjustment, each year that he's been with us by 1,000. So that's
And
not,
what's his highest that he's ever gonna, is there a cap on that of how long if he continues every year, we raise him at 1,000 every year? Or?
no, it's just based off of how much resources he needs, because he has a team himself.
Okay.
We have a one-person marketing department here locally.
Mm-hmm.
Everything else is contracted out.
So, but there's not a cap or anything, it's just decided every year?
Yep, it's just like we review.
Negotiate
Yep.
his,
Uh-huh.
okay. Scott Shepherd, real estate for 13,900 and something, I just wondered what that.
Was that down
It's in
in the detail?
yeah.
Just a
It's
good
just
question.
Scott
I didn't
Shepherd
catch it.
Real Estate, I just wondered
Well,
what that is
it's a lease
for.
housing.
14,000 a month?
But, well, it's a right of use asset, so let me check it. It's gotta be real estate and, hold on.
So it was the first and last months and then deposit.
Yeah, that's
Okay,
right.
For,
Or we leasing?
yeah, what is it?
So we were able to, if I may, Mr. Chairman.
Yes, Mike, excuse me.
Thank you. We were able to, if you remember, we rented a couple of new apartments for Alpine staffing, call rooms, overnight stay, that kind of thing, near the port of entry, those new apartments. And we didn't feel like we were getting the value out of those. They're very expensive. That's all we could find at the time in Alpine. On the other side of town, we found a house with 5 bedrooms and 5 bathrooms that could be used, that we felt like was much more affordable than those 2 apartments we had over by the port of entry. So we were able to get out of that lease at the port of entry and enter into this lease for these staff overnight stay apartments. It's all in one unit. They provide snow removal, they provide everything we need there. Our staff can come and go as they need to at that location.
Okay, so it's not gonna be that much every month?
No, it'll be about a third of that.
So where is that, if I could ask?
It's in,
I know people buy land, so,
well,
and I know Mr. Shepherd, but
it's an established neighborhood, pretty near the Department of Transportation gravel pit storage area and the Colgrove or the Avail Valley storage area. That subdivision right there has been established for a long
Riverview,
time.
okay.
Yeah, that's where.
West Alpine?
Yeah.
And so are they able to park the ambulances and everything there?
No, this is just staffing for the ER and radiology and lab.
So we're
Place for
paying
them to stay.
a place for the ambulances and
Yes,
so
we
we
are.
get double now. So how much is it gonna be a month?
I don't know.
You said 14,000.
4,000?
It's not, things are not cheap in Alpine.
I understand that, and so was one of my questions was EMS, so the one by the port of entry, we're still paying 9,000 a month,
That's correct. That's for where the ambulances
and
are.
that's just ambulance
And-
now.
And it's,
Nobody stays there?
EMS crew quarters too.
So they stay there when they're on call?
Yes, the EMS quarters.
And the other one is for,
It's for
ER.
24/7 ER staff.
Oh, it's ER.
Yeah, so lab, radiology, you have to have all those services to have an ER.
and so we don't have, I mean,
They don't have their own
these are
places.
part-time
Yeah,
people. I don't understand that one, I
yeah,
guess.
me neither.
Jeremy, come to my aid.
Mr. Chair, so the lab and rad staff were there. We staff both of those 24/7 at Evanston, or excuse me, at Alpine. The radiology staff, when they're on their 24-hour shift or 48-hour shift, similar to how they do here, they are in the department a lot of times. They're also here, you see like those RVs that are parked out here, or whatever they're called. They stay there. So if all of a sudden they get called in, then they come in. So that staff is actually working when they're there. The lab staff who use that, they pay for it because our lab shifts are 12-hour shifts. So if a gentleman who comes from Pocatello, he does, I think, maybe 6 days in a row. So he will work a 12-hour shift and then he'll pay us, I think it's $60 per night to stay in that, to stay in the
One of the rooms to the 5-bedroom.
Right.
Okay.
So he's paying for, and the lab will stay there. It's just the radiology staff, because we don't have we don't have hookups for an RV in the parking lot, or we don't have a sleep room for them at the facility. That's why they are at that apartment.
Yes, Mindy.
So I was just looking at the statistics and it's, surgery, I just had a question on this. So surgery cases, it says in 2024 was 299, 2025 was 228, we're down 71. I just wondered if we have any idea why that is. That seems quite a significant decrease in surgery cases, so I was just wondering.
Vast majority is a lot of physician vacation.
Last month was,
No, that's not a month, right? That's in the year?
No.
What page are you on?
I can't remember.
That's a month.
That's in a month?
Yeah,
Okay.
299 to 228.
Yeah.
Year over year.
Okay. Year over year, yeah,
Well, it's May 24 versus May 25.
okay.
So
Yeah,
May
right, May
24
24 to May 25, so it's just because of vacations during
That's it.
2025,
Yep.
May?
That drove a lot of it.
Okay. Okay, that was one question, okay.
Year to date, I mean, 11 months.
Which is
11
like
months
whole
is
months,
up.
just the not previous.
Well,
Yeah,
Mr. Chair, I was
question.
just gonna comment on that, if you do look at the year-to-date stuff, we are up 2940 compared to 2827.
Yeah, I just wondered what that month, what the 71 increase was. Okay. Thank you, Mr. Chair.
My last question then, so we also have a storage unit that I assume has to do with EMS in Alpine for $2,500.
No, it's mostly for central supply and maintenance.
Is it
Because
needed
the
in
building
Alpine?
is
I
not
mean,
big enough.
not big enough? I was just, and I realize this isn't the time for cash, but it seems like we need to use our own land sometime pretty soon to have a EMS building, maybe a little storage or something. Because that's 100,000, over 100,000 a year we're spending in rent. I think we could build something in 3 or 4 years worth of rent. Might last 40 years. I don't know. What do you think? Think it's $1 million to build an EMS building with a,
It's more than $1 million, Mr. Chair.
that's still 10 years and we get 40 or 50 out of it. I don't know. I just, not right now. I
I
understand.
don't disagree with you at all.
I'm just, that just seems like quite a bit. Occupational therapy, we have we're not using the clinic. Says we're paying $2,700 a month for Alpine occupational therapy.
My apologies, that's a misnomer. That should say physical therapy. That's a physical therapy clinic, not occupational therapy.
But it's a separate building than our clinic.
It is, yes.
We have no room in our
We do
clinic.
not for physical therapy.
Okay.
They require their own equipment, their own kind of gym space, their treatment room space, all of that to run a physical therapy similar to what we have in Afton.
So just a minute.
So, Mr. Chair, I was just going to add to that in Alpine, we have started physical therapy and we have a pelvic floor physical therapist that was just hired there. And that building is only being used for physical therapy, a new service and hopefully revenue generating service. And then it's also being used for maintenance and IT as well.
Where is this building?
It is the old Voss Vision building.
North Star Plaza.
Sander still has it by the pizza place?
Yes.
All right. My last question was on employee housing. It says 47,000 a month, seems high, but that's not net, I'm guessing that's gross payout. Don't we get reimbursed for some of that for, Scott?
This month was just shut 19,000.
That we got reimbursed, so there's still a difference.
The majority of that, or a good amount of that is the EMS quarters in Alpine. The rental and thing, the rental and Afton for EMS.
So the three
Those are all.
three EMS stations, well, not the 9,000 for EMS, because that's listed separately. 47 includes your EMS stations,
Right.
which
So-
we don't obviously get reimbursed back for, I guess. They get to stay there free. Okay.
The employee housing, the true employee housing, the apartments that we rent, are all filled right now. We don't have any apartments that aren't filled. We use one of those apartments as a call room for radiology here in Afton and for anesthesia here in Afton. Everything else is filled by an employee and they reimburse us for the rent for those apartments.
You know, Scott, it might be nice to separate that then, because when you see that number and people ask me that, then I go, whoa, that's a lot per month. But I know we're getting most of that back, which you just indicated, Mike.
Yeah, the 19,000, we get nearly all of that.
So I think we ought to have employee housing and then EMS rental maybe a separate lines and have a net for employee housing. So we can actually see that it's a whole lot lower than, it just jumps out at you, so.
Yeah.
All right, that was, yes.
I do have one other question. How much do we pay per month for the rental out,
North of town.
north of town for EMS?
Mr. Chair, I think I answered that. It's at about 2,300 a month.
And why again are we not using the building that we already have over here? Want to
Because,
stay in?
Mr. Chair, can I answer? So the reason for that is because we don't have a place for sleep quarters in our building over here. It's not set up for it. We can't have people sleeping in that area. So we had to find.
Yes.
We had to find.
There's no spring.
But how much would it cost? That's my question. How much would it cost us to put the sprinklers in to make it to code?
Like,
Is it more, isn't it more than sprinklers, Mike? We talked about this a number of years ago.
We studied this a few years ago and it was astronomically expensive. It would have been.
Start over then.
Personally, I feel like the thing we should do is sell that piece of
Yeah,
property
if it was there.
and build an EMS station on one of our lots on Doylestown Circle.
Oh,
But,
another wish.
right, another wish.
Okay.
Okay, that was
Good
just a question I had. Okay, thank you.
No, I remember looking at that because we were housing people there years ago, where we might for a while, and then all of a sudden temporarily, and then they said, can't do that, no egress windows,
No sprinklers.
all the stuff, anyway.
So do we use that building for anything? Yeah.
Storage, the basement's used for a lot of storage, records as well as supplies.
Training.
Okay.
Training Mindy,
Okay.
and then obviously the ambulance phase.
Sorry, Mr. Chairman, I could have asked you.
So, where's my? Hang on, I'm lost. There it is. Anything else on bills against the district? Then we need a motion to approve.
The whole, excuse me, sorry,
Yes,
both items, you didn't approve the consent agenda.
I thought we already approved it. Oh, we approved the consent agenda. Yes. We need now a motion to approve the financial.
You just pulled out items.
Yeah, but that's right. So we already approved the others. So we just need to approve bills against the district.
She's saying everything is approved.
yeah, we didn't approve it.
You didn't approve it.
We pulled it out when we talked about it, we didn't approve what we.
Oh, we haven't approved, so
So,
stuffing it back in and voting on it?
Yeah, I don't know.
Okay.
No, legal counsel says no.
What
Leave it where
would
it
you
is.
like, legal counsel?
You pulled the bills against the district off, out of consent agenda, so if you want to approve those now, you could with them.
So we have a separate motion?
And then a separate
Okay.
motion to approve the consent.
So I'm
agenda.
looking for a motion of bills against the district, approve or not? Not that you can do anything about them if you don't approve.
Yeah, now,
Yeah.
so moved.
I'll second.
So it's been moved and seconded that we approve the bills against the district for May 2025. All those in favor? Any opposed? All right, looking for a motion on financial results, 11 months ending May 2025. Any die for a lie?
So we're not doing the consent agenda.
We need to
Oh.
approve the consent agenda. I so move.
All right, we'll do it with the consent agenda, sorry.
It's on the consent,
Either
there's
way.
one item on the consent agenda, just approve the consent.
All right, let's
Okay.
approve the consent agenda
So
now.
move.
It's been moved by Mindy, seconded by Sean. We approve the consent agenda as listed. All those in favor?
Aye.
Any opposed? Well, I got through that one. Okay. Did you all receive, I think Mike who sent the statistics last month on the comparatives with charge codes? Did you guys ever? I was thinking I asked this to be sent out. You gave it to me, Scott. Would you send it to the rest of the board? This is just some statistical analysis that Scott did on various charge codes against regional charge codes, St. John's, Ermac, and U of U. Figured an average. We're way below on some, and we're high on some, and we're way high on some. So just thought you'd like to have them. As I understand it, it's the only economic comparison that we can make. Is that right, Scott and Mike? Is against charge codes, even though they mean nothing.
Not completely.
Unless you know what the insurance contract is, so. Anyway, you'll get these, they're informative.
Yeah.
Recognize what they are, they're just taking the charge codes on our website, comparing them to charge codes on other websites, which is supposedly everybody's charges, right? And that's, I gather what everybody charges, but then we've also learned that we really only get, and then you have these contractual adjustments so that you have what we committed to the insurance companies to receive. So anyway, just wanted to make sure you guys got that. Next item, Finance Committee. Number one is, well, you can have a general discussion and then audit.
Okay. We, just kind of a quick report. We met last Monday. Of course, approved the minutes, reviewed disbursements on the district. We noted that we would, there was an item on the agenda as far as the coding audit. We actually moved that to July's meeting. We'll get an update on the coding audit regarding as far as the results and how that went. Scott,
So what's a coding audit, if I can ask?
Mr. Chair, can I defer to Scott on that?
Please.
The independent look at a true statistical sample of our, within a date range of charges, right, on specific.
That our people have picked the right charges?
Right, so you take the position documentation and you have to apply a certain code to it.
Right.
Right, and there's rules associated with that.
We have people that do that.
Yeah, so you can, if you don't pick the right code, you can overcode, you can undercode, right? And so if you don't check on a regular basis whether or not you're in line with industry standards, then you're susceptible to billing fraud. And so once that code is established, then that drives the charges, right? Which then drives the payment. So it all starts with coding of your documentation from your providers.
So they're checking to make sure we picked the right code. Okay. Thanks.
We didn't go through the results, Mr. Chair, but we need to go through the results.
No, you're gonna do that next month, which is fine. I just wondered what an audit like that was. Cool.
Scott, to give us just a brief update regarding the revenue cycle consulting. The consultant is now engaged and on site. How often on site? Is it a couple days a week?
Monthly or something, isn't it?
In bands.
Yeah. He wasn't here this week.
No, he was here 2 weeks ago. He provided us with a report on his findings and his recommendations for implementation of additional measures regarding revenue cycle. Next week, we'll reconnect with him and kind of give him a brief as to how things are going based on his recommendations. There is still a short list of items that he would like to audit for us to give us some additional recommendations on other portions of the revenue cycle. And we'll probably ask him to come back sometime in the month of July for a few days again, spend a few days with our teams and then provide us another report and recommendations again. So it was very beneficial.
Great.
We also did Trevor and Ryan were kind enough to give us a deep dive for the month on EMS. And with the report, I didn't know is in the board
It's on a
packet.
different line item, so let's talk about it then when it comes up.
That's fine. I was just gonna say, we did go through that. It's great to have that deep dive. Speaking of the deep dive, we do have an agenda that there's a number of items that we want to do a deep dive on. I'll get together with Scott here later, and we'll try to pinpoint or pin down an exact agenda of what we want to do, look at monthly. I know to you the other night about it. If any of the other board members feel very passionate about one thing or another that we ought to be looking at financially, please let me know. But I will fine tune that with Scott. We'll kind of do a deep dive every month just to look further into each, some of the things that some of the investments we've made and some of the things that are getting scrutiny financially. And then as far as the financials go, just quick summary, there was a, month of May showed a net loss of 357,000. EBITDA was just barely positive at 163,000. Fiscal year to date though, EBITDA is 7.7 million. Trending good that way as far as cash flow in the fiscal year. Days cash on hand, we lost a few days cash on hand down to about 55 now, which I think that was that was expected at this point in time, considering the cash that we have going out to pay off some of the short-term debt. Days revenue and AR of 76.3 continues to decrease slightly, which is a very positive note that we are collecting fees faster than we have been previously. So again, just a couple, that's kind of the highlights from the financials I pulled out to not get into it. I mean, the financials are there to review. I'm happy to answer any questions if anybody has any other financials, but not get into the weeds on those.
Questions, Sean? Over here, okay.
The report, the EMS report, was that something they were doing anyway, or that's what's reflecting what they asked for? Do you know what I'm saying? Did you ask for that?
It was the one that I asked Trevor to complete for the comments from Mackenzie at the last meeting. And he's gonna report on that at a later time in the meeting. So he did make that same report already to the finance committee, is what I understand.
Yeah, so and I'd actually specifically asked for the deep dive EMS in June, just because of some of the comments and stuff that was going, surrounding that department specifically.
You also looked at the ER at the same time, is that right?
Yeah, we primarily concentrate on the EMS. So we briefly touched on the CapEx, the operational budget. Basically, the changes that were made were the changes that we discussed in the previous board meeting. And, it's there for you to review. Again, if you guys have any questions, I'm happy to try to answer those. So with that, that's really all I have as far as the financial report.
Good. Next item, still under finance committee is anybody, I think, questions on we have the final audit report. Finally. I wasn't going to say that, but I thought I would anyway. Scott, sorry. Anyway, we've got it. We've got all the what was it we needed from First Bank? Not a consent, but a write-up.
The waivers on covenants.
Waiver. That's the right word, not write-up. Okay. Anybody have any questions about the audit? Would you like to make some comments, Scott?
Because I don't know if it's been discussed in here, but one of the waivers included an amendment to the loan agreements that would change the days cash on hand covenant beginning Monday, 60 days. Next year, 80 days, 2 years from now, 100 days. So they agreed to amend the covenant and stuff for the next couple of years.
Awesome.
Any questions about the audit? As far as I can see, the audit, why don't you read it? It's basically, what do they call it? I'm going to call it a clear audit. What is it, Dan?
Clean opinion.
What is it? Clean opinion? And a clean opinion, no material, and they're showing the way it is. The benefit we also got is, as I understand it, is we've had about 11 months of this particular fiscal year almost audited. So next year should go pretty easy, and we still haven't seen any real problems. So, okay, I need a motion to accept the 2024 audit as completed by Ide Bailey. Moved by Cole,
I'll second.
seconded by Abby to accept the audit, the 2024 audit report from Mike Bailey. Any further discussion? All those in favor?
Aye.
Any opposed? I would encourage you, if you have time one night that you want to try to fall asleep, read the audit. You're having difficulty counting sheet. Anyway, there is some good information in there, but accountants are kind of boring. You gotta read it when you're awake. All right, we're on to budget, 2026 budget. Scott, are you want to present that? I guess everybody has what we have in our packets.
Yeah, I can do that. So the last time we met, we presented an initial plan. We made several adjustments to it. Does everybody have that?
Proposed operating plan. 100.
So the proposed FY 26 operating plan, there's two columns. One says updated.
What page is that?
100, yeah.
Okay.
So there was a few modifications and refinements made during the time since we last met. It increased the net income from 41,000 to 413,000. EBITDA from 7.4 million to 7.5. There were smaller but necessary refinements to the previous plan that was presented. But one of the bigger ones was we find the interest expense down about $800,000, but we had to increase the locum budget, actual. So anyway, but it didn't change materially, but it went to 400,000 on the net income side. Revenue did not change. And salaries, wages, and benefits did not change. Those are the biggest numbers on. Anybody has any real specifics? I can answer that.
Questions for Scott or Dan on the proposed operating plan? Abby?
We're anticipating 1.2 million in anesthesia locums, even with 2 new anesthesiologists coming online. Okay.
That's net, as I understand it. Good question, because I saw the same thing.
But what do you mean? You mean
Well,
that's everybody's
it's-
wage in there, or is it?
No, it's counting the new anesthesiologists that are coming online.
Their wages in there?
Locums are going down.
One of the anesthesiologists is actually not gonna be employed.
Oh.
So it's gonna be like a 1099, so that's the budget line item that we put.
Okay.
How do they be a 1099, if I could ask that? Having been in trouble with the Fair Labor and Standard Acts before.
So we have relationships with
Dr.
physicians where they can be independent contractors or they can be employed.
So they bring their own equipment?
No, they bring themselves. They are their own entity.
Dr. Beagle was like that, right?
He still is. He's part of a group, an independent group.
I see a group, but an individual 1099, isn't there a fine line between an employee and a contractor?
Only if you're supervising somebody, like you.
I'm a 1099.
Trevor, you have a,
Okay, so there is a fine line, and it's based on the independence. If they have the independence to make their own hiring and firing decisions, then they can be considered a 1099. And so they basically have the oversight and the management of their group, even though they are working within the organization. So we don't employ a lot of, I think where we get into trouble is if we were to take like a staff employee and say, oh, you're an independent contractor. I think FLSA would probably question that.
We're not allowed to insure them.
so in this case, it's a one-member group?
Could be.
And you're feeling good that we're not that's all I want to know is we're not in violation.
Oh, without question, Marlo.
Because
most hospitals actually not most, but there's lots of independent doctors that have contracts for call, for services being provided. So it's not, even though we employ the vast majority of our surgeons. So it'd be him. We have our urologist, Dr. Johnson. He's independent.
Yeah, but he's a visiting. I mean, he just.
Yeah, but
This guy's a full time for us.
Yeah, but there has to be a contractual relationship of, you know, depends on the financial relationship and the extent of that financial relationship. So for his time, we negotiated, so we're not paying benefits, right?
Understood.
So he's in charge of his own malpractice. We're not paying malpractice. And so it's very common in the industry that you can either employ the doctor or you have a contract with the independent person or group.
So he's then got his shingle out to be hired by anybody else also?
That would be correct. However, in our agreement, we have certain service standards, right? So if he's not making himself available or the quality of service, then obviously we look to the contract to remedy that.
HR, you're the man for this one.
I feel
Are
100%.
we within the rules of FLSB?
Yep, I feel 100% confident with.
Sounds great with me then. Other questions? On the budget, I guess we're back to, I went off on that tangent, but I had a couple, locums and that was good to hear. Just, obviously, we're trying to have more reserves, right? We're trying to gather more reserves. And as I look at our budget, I see that basically wages and salaries are almost 70% of our budget, right? With benefits and health benefits. The question, I guess, is are we too fat? We got too many? I have a former CEO that talks to me every once in a while, and he always said, you know, I've never seen any time that I've had to call the ambulance, come and pick up somebody because they were overworked. So my question is, do we have some, and I'm not saying we need to lay people off. I'm just saying that's our biggest budget. And one of those levers that we talk about is expenses. And through natural attrition, retirement, other things, do we have more positions than we need? And I don't know what it is. Do we have a standard in the industry of what that percentage should be, or how many total people we ought to have? How many administrators, how many staff? How many, I mean, we just read about providers. And so I'm just wondering, and I'm not saying we need to change it in this budget. I'm not wanting by any means for anybody to think I want to start slashing staff and laying people off. But I think we need to look at our largest factor and say, are there efficiencies? Is there fat, I guess is the word I use. Can we trim? Can we be more efficient? When somebody chooses to retire, do they need to be replaced? If somebody changes their life and they move somewhere else and leave our employment, is it a position to backfill, or can somebody else take a little bit of the load? We lost Mr. Taylor here a month ago, Mark, and we didn't backfill that. Obviously a good decision. We found somebody that could take the load that I assume he had. So that's my question on the budget, and I don't know that I'm asking this to be changed, and I hope we're thinking about that every time in our departments. But I think it's critical because it's the largest lever we got, and it makes us why we need to make 120 million a year.
Mr. Chair, may I speak to that?
Please, Dan.
So one important point that the board needs to remember with our organization, and it ties exactly to our strategy. How many locations do we support? And the economies of scale that you lose when you just don't have one location. So when we made the decision to go to Alpine, what additional incremental staff do you have to pay for? The housing, everything associated with that to pull off that access point. And that is a major contributor to not having the efficiencies of just having one location. So with the adoption of the strategy comes the concern about, well, all right, sustainability and how do you pay for this? So that's point number one. Point number two, I think that over the last 90 days, the board has seen that we have had serious discussions about staffing. And we've also got a lot of pushback from community members for making those decisions. And we continue to have discussions internally. We still have a freeze on no new hires, right? And we're having ongoing discussions about, can we somehow figure out how to do more with less, with every single department. So EMS, you brought up Mark Taylor, the urgent care up in Alpine. Employees, community members, they don't like it. But we have to make those decisions.
How to run a business.
You gotta run a business, right?
Gotta do what's right for the business.
And so in all of this, we take it very seriously. We try to figure out, how are we going to sustain this strategy? By having all these access points, providing these services. When you see the numbers associated with healthcare, it's in the people. And if you can't figure out a way to have enough people to cover a 24/7, 365 operation, you don't have a functioning hospital. And that's the name of the game. So we acknowledge a very valid point that we, as managers and operators, ask every single day. Because ultimately, we have to have the cash to pay for things. So there's nothing in that line item that we haven't scrutinized when it comes to staffing, wages, and benefits. We're always looking for, how can we somehow pay less so that we can drop more money to the bottom line and build those reserves. And that's really our sole focus this coming fiscal year.
Mr. Chair.
Cole, yeah.
So,
comment.
Dan, just to your point there about the benefits, can you talk to us? I mean, we talked here a month or two ago about the expense of the health plan, and can you talk to us about the specific number, why it's budgeted this way, and maybe what alternatives you've looked at?
Yeah. So the benefit structure does not coincide with the fiscal year. That's point number one. So our fiscal year is June 30th. Benefits happen January 1. So this budget represents 6 months of a potential benefit change.
14.5 million?
Yeah.
It's just 6 months?
No, what I'm saying is, if you're going to make a change, you're only gonna get 6 months.
Gotcha. Okay.
Right? So
I'm with you now.
there's really not much we can do right now that's going to, we're already gonna be 6 months into the fiscal year before okay. So that's point number one. Point number two is, we sat down with our existing broker. We did not do this last year. And we said, we doubled in our expenditures. We want to know, I know that you only have a couple months of data, but you got to tell us, how much are you projecting that we're going to spend on our existing population based off of the historical data that you have? So they have actuarial lists. They're able to look at, hey, here's the health conditions of each of your employees, and looking at the future of this fiscal year, where's our spend going to be? Well, that went from 14 million to 16 million. So then that triggered, this is ridiculous. We're in business to basically provide health insurance for our employees. I mean, how do we absorb another $2 million?
Employees.
How do we absorb another $2 million of expenses, right? And every listen, we're not alone. Every company out there, I mean, this is the whole reason why we're having conversations with Cigna, right? Everybody is trying to figure out how are they going to pay less with this whole health insurance stuff. So we then had conversations with a different broker who they boast that they can be more proactive in trying to bring down that cost for a self-insured population. We had a conversation with a company out of Utah that is bigger in scale and size than our current broker, and it was very enlightening, but we don't necessarily know if we're going to go down that road. That was conversation number one. Conversation number two, Marlo says, hey, I was just talking to the county commissioners. They just changed insurance companies to Blue Cross Blue Shield of Wyoming. There's a government plan with Blue Cross Blue Shield of Wyoming that they've saved lots of money. So we have been in contact with that governmental plan for Blue Cross, and we found out that there are several critical access hospitals that are participating with the school districts. We don't necessarily have all the results from that, but we are looking at every option possible to say it's unsustainable to go up 50% this current fiscal year. What's 2 million over 14? Another
30-40%.
Okay, another 30%. Another 30% this year. There is no way that we can sustain our business by providing all these wonderful health benefits to our employees and pretending like we can produce enough money. Then the balloon squishing is this. Well, how are you going to pay for it, Dan? I've got two levers to generate revenue. See more business or increase our rates and negotiate better contracts. And I will get hell if I increase rates. Okay? I'll get hell if I cancel a contract. I'll get hell if I want to expand to try to increase volume. So guys, we have to figure out plausible solutions to solve all of these. They're not isolated. It's all connected. And that's what even our own employees and the community, they really don't comprehend the number of dots on this connect the dot paper of what's necessary for an independent facility of our size to remain viable. So with this budget, with every line item is a story about how are we going to pay for it? What are we going to need to do? And there are things that you have to give up, and there are trades, and people aren't going to like it. And that is the wonderful position that I and my team enjoy. And we need the board to understand all those dots connected. We need the community, our employees, to understand how all those dots are connected, because this is not sustainable.
Do you think the community understands that between the school and the hospital, we insure just about everybody in Star Valley by a spouse or a child or something? I mean, it's got to be. In the other smaller businesses, they don't always have to have insurance because one of the spouses is an employee of the hospital or the school district. The school district used to have a Cadillac program and everybody loved it. And it's changed. Yeah. So anyway, I'm just saying, I don't know that our community understands the dollars that we're spending. You're spending as many as.
Sorry, I don't know if that's more information that you wanted, Cole, but.
No, it's actually good. Number one, Marla, to answer, to just as a side point to answer your question, I don't think everybody does understand that. Just from the standpoint, also, when you hear these things out in the community saying, hey, don't support Star Valley Health because of this or that, you also, but then you turn around and it's like, oh, but your neighbor works there and your neighbor over here works there. And so it's like, don't support the people that employ your neighbors. It's a catch-22, and you're not gonna make everybody happy. But the reason I bring this up is I know, sitting here looking at the financials, huge increase year over year, expense-wise, what we've seen this last year. And I think because, to your point, Dan, it's a timing issue. Like once you decide whatever we're gonna do for the next year, we're locked in for another 12 months.
Well, really, if we lock in in October, November, it is really 15 months.
That's fair.
Right?
But my point is that, I think it's not all that, far down the road and we have a lot of dots to connect. I just want to make sure that we're looking at some other options and not just saying, hey, this is what we got to do.
We're questioning, and again, we're not the only ones out there. Every hospital right now is questioning anything and everything about, all right, how are we going to do this? And what gives? Something's got to give. And frankly, I've been commenting to my management team, I'm just ready for the whole healthcare Ponzi scheme to collapse in the country.
No, that's Medicare.
Well, it's something has to change. Otherwise, it's just you.
Yeah, we don't disagree with you.
It's almost impossible to try to manage this.
Last comment. I just know our margins just not high enough to get 6 months into that and be like, oh, we should address something, right?
Yeah,
so
you're right. You're
that's
right.
my point. I'll leave it alone.
Thank you, Cole.
Is it possible that we won't make the final decision, but it's something that we want to stand with you on if it makes a good, for the organization? I'd really like to.
Get ahead of that. Yeah.
For sustainability, like just off the top of my head, it makes tons of sense to go through Blue Shield, but I know that when we went from self-insured, the first bougie Cadillac plan and then made some changes the next year, there was a lot of, like, people felt like a pay decrease,
So
but
what
I'm
about-
saying that kept you.
What about
I can see
80/20
that.
co-insurance?
I've seen that. My husband's job offered 5 plans this year to choose from, and they wanted everybody to do the 70/30, and they put money in the
Oh,
HSA.
70/30 now. All right.
Well, they would stock the HSA for that, but like, we can't make that decision. We have to just pay.
Yeah.
A lot of plans,
For
a
the
lot of
bougie.
companies are 70.
Yeah, it wasn't surprising to me to see that change needed to be made because his employer employed a lot of people and they need to change. So I'm anticipating this. I'd like to stand behind you strongly. Like, let's just, like, this is like the match on the retirement on this issue. Though you don't have to ask our opinion about it. I really would appreciate seeing it before you pull the lever.
Well, and I think everybody, at least not everybody, but the people in this room that have been part of all these discussions, we cannot be everything to everybody.
Right.
Right. So let's just, EMS, for example, we're 18 months from our agreement that we made with Thane and Alpine. We have now completed individual meetings with all the mayors and their administrators. And we have given them the report, we've outlined to them and said, the hospital has stepped in and elevated EMS in this valley where nobody else could. Nobody would touch it. The county wouldn't touch it. The towns wouldn't touch it. Everybody wants it, but nobody wants to pay for it.
Totally.
Okay?
And they're not mandated to pay.
And they're not mandated. So if we didn't do it in this board, and we're not mandated either, right? So we made the decision to do that. Now we have to ask, what's going to happen in 18 months? And so what we're trying to do is bring all the stakeholders to the table and say, guys, what do we want as a community? And so that, did we do the right thing by bringing all under one umbrella? Absolutely. Did we do the right thing by investing in training and elevating the care? Absolutely. The response times are totally different than 3.5 years ago. Now that it's under one umbrella, we have to ask the question, what gives? Because we've told every one of those leaders, this is unsustainable for the hospital. All of our tax levy is going towards this, and in this year, we're projecting an additional $1 million DMS. But the community says it's not enough. You need to have more staffing. You need to do this. You need to do this. I'm sorry. We're paying for it. And if somebody has a solution of how to pay for EMS, I am all ears, guys. I don't want to pretend like I have the answers here. But I see a lot of criticism, but I don't see a lot of solutions. And that is what I'm after. I'm looking for people with solutions, real solutions. And it's very scarce.
Abby.
So I saw that this town of Star Valley Ranch pays into the MS from that report that Trevor provided. They just choose to do that?
We negotiated that because they didn't have any assets to contribute from the get-go.
And so some of these other cities did.
Yeah, and Star Valley Ranch was already paying Thane. So we just carried that over to bring it under, to help them.
And then this is probably gonna make me look stupid, whatever. The money we get from the Lincoln County, the assessment.
The mills.
The mill levy.
Tax.
If you're within a town limit, is that a different thing than like I'm outside of the town limit? Like, if you live in the town of Thane, are you getting taxed at whatever rate you are, and some of that's contributing to the overall Lincoln County mill levy? Or are you in that little chunk in the town limits of Alpine, Thane, Afton?
That is,
you know what I'm saying?
No, I don't. That's outside my expertise. I don't
You know?
I don't
Can I
know
answer
the answer to that.
Yes.
I think it's, they pay an additional up to 8 mills in a town. So they pay what you pay in the county.
Uh-huh.
Plus the town can add on an additional 8 mills. Usually they net it at 5 because they do take away, if they have a fire district,
Uh-huh.
then they don't have to pay something. And so it's between 5 and 8 mills that the towns actually pay in addition if you're a citizen of the town or have land within the town. You don't, some of us are taxed without representation in towns. Is that the way to put it, Mike?
So every piece of property in Lincoln County assessed mill levy across the board, whether it's within the confines of a town or in the county limits,
I think the county
is part of that 1.2
12
million.
max. I think the county can do a 12 mil max. They can adjust that to save. But if they're not at the top, and the towns are usually the same way, then going to the state of Wyoming and asking for any money out of SLIB or any other of the grants, they say, if you're not willing to tax yourself with a max, don't come and ask us for any money. That's been the historic decisions in the past.
Really clear. That's good.
That's what I know about.
Yeah, that's what I need to know.
All right, other comments, questions? I had one more. That was on the revenue lever. And again, I'm not disparaging anybody. Obviously, we have providers that work really hard. And my question is that are all our providers doing all they can? Or is there some slack, or do we have any, Jeremy, I don't know if the quotas is the right number. I know I have relatives that work for IHC and the docs. They have certain things, certain number of people they've got to meet every day or something. I don't know all the facts. I don't remember all the facts. I'm just wondering, they all do a marvelous job, but are they doing all that we require them to do, or do we require enough out of them? All docs. I'm just providers, not just docs. And I'm going to get a lot of flack for all of these questions I've been asking. But anyway, it's asking. Jeremy?
Yeah.
Is there an easy answer?
Well, I know part of it, and perhaps the doctors next to me who do well above and beyond what we expect of them. They're fantastic, but we don't, I know you're talking about some organizations that will have strict standards, say, you have to see this many patients, or you have to do this, or you have to do that. We do have expectations set out in our contracts related to behavior, related to chart closure. We don't set a certain amount of, you have to see X number of patients per day. We allow that more to the providers to determine. Some providers in the same specialty see more, some see less. And so there are some doctors who I've been in meetings with Dan before. We're talking about not a production issue, but a different issue. And one of them said, look, we chose to come here because you're not IHC. We chose here because we don't want to, practice that. And so we have different standards, but compared to national standards, how do we do it? It's a difficult discussion because when you look at Linford and Stuckey, well, they're not producing at the 75th percentile, but when you're comparing them against an orthopedic surgeon who lives in Chicagoland, who works at one hospital, whose patients all come to see him or her in that one clinic, it's hard to compare to people who are driving or flying 2 hours to different clinics and going from place to place to place.
Right.
So, could some individual physicians produce more? Sure. Just like, some EDS people clean faster or whatever, but we don't have a set standard that says you have to be this percentile.
We do have a standard of what's called bookable hours, Mr. Chair. Maybe you can just explain bookable hours or availability. Because of our rural environment, and again, the whole population, this goes back again to the whole strategy of population and sustainability, right? Is what can you sustain financially? And so if we feel like there is something, a reason why a physician is not busy as they probably should be, we're having those discussions. Every single physician that we meet with them one-on-one, what about this? What about this? How about this opportunity? And it's collaborative. But maybe you can explain bookable hours.
Bookable hours are simply something that we use for not all specialties, but for quite a few, where we say, you have to work full-time. Great, what does full-time mean? So if you're a primary care physician working full-time, that means you have to have 34 bookable hours per week. A bookable hour is time in your Epic schedule where a patient can be scheduled in there. If you put hold or lunch or something else, that doesn't count as a bookable hour. And so they have 34 patient contact hours, bookable hours, that are in that clinic setting. If they don't fill their calendar, it still counts as a bookable hour. And so that's our standard. A lot of specialties have that. It's a way of helping determine what does full-time look like.
So they have to be available for those.
Yeah, they have to have it. Their Epic, I have to be able to freely schedule into their schedule without a block or any kind of limitation.
Yeah, if nobody schedules, it's still a bookable hour.
Right.
Even if they didn't see anybody.
Right.
Yeah.
Yep.
Anyway, I just think it's one of those levers we need. And I know you guys probably think about these things day in and day out, because I don't, except
these are great questions.
On the last Wednesday of every month. And so, go ahead.
Yeah, just to add to that, I think that it's important that we're looking at, and I think we're relying on Dan and Jeremy to monitor the individual production. And, even though we don't have set numbers per se, I mean, I'm assuming that we're relying on them to look at, is there opportunity costs? Are we not only are we meeting, what do we need out of that department, clinic, individual, whatever it is? I'm assuming you guys are monitoring that. That's kind of, and have expectations and meet with the providers and so on and so forth, and discuss those expectations that you guys would have. Is that correct?
That's correct.
Okay.
If we were to, when working with physicians, there are some administrators that think that they can just, that they're shadowed, that you can just tell them that you have to do this. Doctors are not wired that way. Doctors want to be able to control their practice, and it has to be collaborative. You don't last too long by saying, doctor, I'm the hospital administrator, you're going to see this number of patients, and you're going to do this and this and this, end of discussion.
No,
there are some systems that want to do that, and they do that.
I think it's
right?
gotta be collaborative.
But in a rural setting, they're your partner, and you have to treat them with respect, dignity, and have a conversation with them and understand where their pressure points are. And if you don't do that, it will fall apart.
Mr. Chair.
Sure.
I can say one more thing. One of the cautions I've had too, when we look at, if you brought an outside consultant and they say, well, let's look at this doctor's productivity and this doctor's productivity, use a very traditional measure, right? Work RVUs. So much of what many of our physicians do isn't trackable by a number on a piece of paper. Whereas if we were in a bigger city or a bigger market, you could see, you would be off of work RVUs. You'd be off of all these standards. And so, you don't know we have just two general surgeons as opposed to a group of 6. You don't know that half the time they're on call. You don't know, so if you just look at some individual numbers, it's challenging. So back to Cole's point, we do look at, okay, what is our overall expectation from coverage expectations and teamwork expectations, quality measure expectations. We do look at those, but I'd say we look at some of them in a slightly different way than you would if you were staffing only for volume. But we staff for more than just volume. It's coverage, without our general surgeons, we couldn't have our ER, right? And so some of the traditional standards don't apply as well in a situation like this. So,
cool. Can I just follow up on that?
Yeah.
So what, say you have somebody that's not meeting, you're like, hey, we really need this out of this.
34 billable hours.
Yeah, whatever it is. How do you address that?
Well, so the bookable hours, that's easy. The bookable hours is, we review their schedule every once in a while to see if it's changed. And usually we talk about for change, but if it changes, we just say, okay, if you want to work 30 out of 34 bookable hours, 30 divided by 34 is X. If you're full-time, you get this much, so you get less of that. If a provider had issues, say in primary care, we have a lot of quality measures, and if they're not meeting the quality measures, then we work with them to say, okay, here's a workflow that, like say Dr. Millison is doing this workflow. You should try working on do this workflow or whatnot. In the primary care compensation model, their compensation changes based off of whether they're hitting certain quality measures. And so we provide ways to get to those measures if they choose to do those. But if a doctor isn't, Dan and I met with a provider about a month ago to say, hey, you're not producing at the level that you should be producing. Let's talk about why is it happening? And so the provider brought up, well, I have some concerns about this or concerns about this. So we want to understand what are the barriers in this provider's way. If it's just that the doctor's like, I just want to be lazy, which we don't have a lot of that, then that'd be one thing. But most of it is what barriers can we remove to help you to be more productive to get to where we need you to be. And so it's a lot of person-to-person conversations, as opposed to we look at a number and say, you're clearly failing, it's more of a, here's your number, why is this your number kind of discussions.
Anybody, anything else on operating budget? That's what we were talking about. And we need a motion to approve the 2026 fiscal year operating plan. Excuse me. Try to change my language, Scott. You can charge me $0.25 every time I say it wrong.
This is just operating plan. You're doing the CapEx.
I'm doing them separate, yes. What page in the packet are we on?
I'm making a motion to approve the fiscal year 26 operating plan as proposed.
Have a motion to approve the fiscal year 2026 operating plan. Have a second.
Second.
A second by Mindy, approved by Cole, or moved by Cole. Any further discussion? All those in favor? Any opposed? Okay, moving on, I think next is CapEx. Capital expenditure budget for 2026. Questions?
I do have a question on that. So the Alpine Clinic, 400,000, is that still the helipad that they're still wanting, or is that something else?
Go ahead, Scott. Thank you.
It relates to the new X-ray unit, and it's required remodel, if you will.
As well as some additional cooling capacity in the lab, since the new equipment in the lab exceeded our capacity to cool it.
Okay, thank you for the, okay,
For any of the helipad was taken off of the budget
okay, good. Okay,
till next year.
okay, that's what I was hoping.
We're
but that's
trying
just
to
something else.
negotiate, start, didn't I, oh, is it, that's in your report, isn't it? We'll see that later, okay. Other questions on CapEx? Anybody? I have some, God. Sorry about that.
You already gave me a heads up, so.
My question is, we're in a period where we need to have reserves. And this is 3.7 in regular and 2 million out of Diamond Bill. How many of these things can we, I mean, if we didn't buy them, could they last another year? Are they absolutely necessary? I mean, I look at some of the, these aren't CapEx items before you go there, Dan. I looked at the leases that we pay on vehicles. And I don't know why we're buying 20 brand new vehicles so they depreciate 25% when you drive them off the market, off the lot, instead of leasing 3 to 5 year old vehicles that have 75,000 miles on them. They operate just the same. They don't have the new smell. They may not, and they can look about as good, in my opinion. That's been my operation. And you can still run them for 10 years before. I mean, today's vehicles are a lot different than they were 30 years ago when vehicles didn't last very well. So when I talk about CapEx, and I know those are leases, but those used to be CapEx.
Yeah.
I'm just wondering, a great way to increase reserves is to spend less. Are there things, and I know we have A, B, and C priorities, and on the main ones, we have 2.2 million in priority A, and I understand that is absolutely needed, or is it, can we get with that, can we do without it for one more year? That's my question.
Mr. Chair, let me take a first stab at that. The organization goes through a process of harvesting the needs of the organization. So a capital budget process is one of the biggest benefits is identifying from your people, do they have the tools and equipment? Where are their concerns? What are the issues? Are you concerned about this piece of equipment outdating? We can't do our job without this. We haven't considered this in this particular expansion, and now we need to. And so just by going through the process, you harvest all of these items. That's part one, right? Part two is, how do you pay for it? And if you can't pay for it, do you defer it to other years? We've been deferring things for years and years and years, right?
They're still running.
And they're still running, right? So, and
praying a little
and
bit.
they're praying a little bit too. And so you always have this tension in the organization. Well, we asked for that 5 years ago, right? So why are we going through this process again? Well, the answer is we want to hear from and understand and look at how to plan accordingly, right? If we can do it, let's do it. If we can't do it, we deferred another year. So we're used to deferring, and we're used to figuring out what's necessary for us to, what's absolutely necessary. So are we approaching where our prayers will not be answered, that the roof doesn't stop, will start leaking? The answer is, we feel very strongly that we've got to pay somehow, some way for a new roof. And it comes to the point where you're like, you know, there's going to be folks that say, no, that was more important than this, right?
Got it, yeah.
In our opinion, this is more important, and why didn't you guys do this? And again, scarce resources really put pressure on an organization like ours, where it's high capital, high dollar, and answering the question, how do you pay for it? And at the same time, increase reserves. So we have spent countless hours as an admin team having discussions about that. What are our priorities? So I want to be very clear. Our number one priority this year is not capital. It's our people.
Same.
Okay? So we are electing to not spend dollars on certain capital items, even though we harvested them, we categorize them into A, B, and C. But what's not on the list is that we are going to continue to make financial investments into our people. Now, some people will say, that was stupid. Why do you make that decision? Well, guys, you can have great equipment, and we have wonderful equipment. But there is, healthcare is based off of your people. That is the secret sauce of this business. If you treat people right, it can be a very good business. Now, there might be some creative ways that we defer, or we lease, or we do something where it's not a chunk of money going outside the organization, but it's spread out over a period of time. That's for us to figure out as administrators. We're giving you this list to say, here's what we've harvested, here's how we've prioritized it, but just know that our number one priority is our people. And if we have to figure out a way to push most of these millions of dollars to another year, we're going to do that.
The people's over in your operating budget.
Yes.
So your column A, I mean, that's 1.5 below the 3.7. Those are the ones that I assume are a must.
Yep.
They've risen to the level that the roof might be. But there's a 1.5 million savings right there. They're cash.
We know it.
In reserve. So I'm
we know it.
Just wanting to ask that question. Are there any other things? I know you guys have looked at this. But I want to ask the question in here, what you guys have done in the process.
And really the
B and C, what are we doing with those then? I mean, if we add those into this budget and agree to it, then you're allowed to spend that 1.5.
Yeah, so again, I think the board is saying, Dan, increase your reserves. Got it. Thanks for the marching orders, right?
Yeah.
If I could increase the reserves and also help with these capital expenditures, I think I'm hearing from you, do it, Dan. But what is the priority?
I have a question. Do we have to meet the 60 days cash on hand by the end of fiscal year July?
Yes, we will.
Monday.
It's Monday.
Monday?
June 30.
Like, so that's not happening.
Yeah.
Yeah, it could.
Getting close.
It's gonna be close.
Like, didn't you tell me it was 40 something? And
Well, that was the end of
No,
May.
it's like
50
55
something,
right now.
55, okay, that's totally doable. I mean, that's like me wanting to lose 20.
That was cute, Abby.
Well, I mean, there are things. Okay. I mean, I have an opinion about this, but it seems like this is good to hear. But it's, sometimes you hear things and then it's like, what the hell happened? So we hit their days cash on hand covenant. Then we have from Tuesday till next year.
To get to 80.
To get to 80.
Yes.
And that we could make an agreement that like, for every 5 days cash on hand, we like take one of these projects off, starting with the cheapest one and getting to the most expensive. So
have the money we spend.
yeah.
Yeah.
I mean, is that how you operate?
It's not like that, but it's.
I know it's not.
But the point is scarce resources, right? How do you invest in your people and how do you create reserves? What gives? Well, we might have to defer some of these capital projects. We're asking to approve this amount.
Yeah.
Because, our strategies and our decisions could pay off mid-year. And then we make.
We have more reserves.
We could have more reserves if that's what the board wanted. All I'm saying is don't, give us the flexibility. Give us the flexibility to figure out how to do all three of them.
You're gonna take care of the people, you're gonna get 60 days cash on hand and work up the A list as you can.
That's exactly right.
Sounds really good.
Mindy?
So, Mr. Chairman, I have a question.
Yes, Mindy?
So I just want to make sure Diamondville is not in this, right?
Yeah, it's on the bottom.
Diamondville is a special project,
Okay, it's not in this CapEx, though. I
but it's
wanna
not in
make
the,
sure.
it's not in the routine.
It
Right.
is in the CapEx, but not the routine.
Where's it at then?
Start at the bottom. Total special project capital.
I have total routine capital.
Here's the list I have.
I don't have that list. I don't have Diamondville Clinic on my list.
Is that not in the packet?
So is it 5
Yeah, the 2
million?
million, I don't know what.
But our numbers are still what Marvel's.
No,
are.
they aren't.
There's not.
3.7 and he's
Well,
got 5.7.
Yeah.
You didn't get the updated list.
No. So I
It should
don't,
be, Ender said updated. list.
Okay, so we don't, this one that's in the packet,
it's not the right one.
yeah, it's not the right one.
So I don't agree with the 2 million for Diamondville.
Okay.
I don't think that's necessary. If you take $2 million divided by, didn't we say rent was 3,500?
No, we haven't figured that out yet. We
I
have
thought
a
Mike
final
told
number.
us last week.
Well, he did last
Or
month,
last
but I
time.
think they've been working on that to define it a little
That's,
better.
that's 571 divided by 12. That's 47 years you could,
Yeah, so here's what I would propose.
I mean,
Mindy, it's
that's 2 million's a lot of money.
it's
for-
a valid point. Here's
Yeah.
what, so special projects, you recall last month.
Well, I remember we talked about it, but I didn't see it on my list here.
So
That's
we
why.
could, the board could approve the special project, but obviously the budget.
Okay,
But when and how that
you
actually.
would talk to us about that first?
Absolutely, that's why we have it as a special project, is this is not routine capital, so we need flexibility to make some decisions on a $6,000.
Yeah, I understand that,
Yeah.
but the 2 million, it's
But-
not on here,
But
and
the
so
2
that's why I
million,
was
the
asking.
2 million, there is no way in heck, there's no way in heck that we would just move forward without having a robust discussion
Okay.
about when and how that would happen.
So what I would actually like to see added to that, I don't have a problem. I mean, actually, I believe in the Diamondville one a little more than Minnie does, but I agree that we ought to hold off until we have the money and the reserves. And I'm wondering if B and C ought to be in the same category, that you come back to the board when we're gonna spend something and call them B and C and show us where we're at cash wise.
I mean,
That's-
they'd have all of A done.
Yeah, no, we're going.
I know you probably will.
I think
but I'd like
on a
to
very
structure
regular,
that
we
way.
were planning on a very regular basis to let you know.
Where
I mean,
we're at.
Listen, this is a lightning rod, right? Is we're gonna be having discussions about cash, capital, and people every single freaking month, right? So let's just have those conversations. It's naturally gonna happen.
And as long as we're on the same collaborative discussion with that, I would agree. I think Diamondville is. If it's right and we have the money, then it's probably something to look at. There's probably something else we can do maybe. B and C, A is what we've got to have. So I have no problem really approving the column A.
Mhm.
B and C, we
It's
don't
special
have the
project.
cash. We got to think about it at least twice.
Mhm.
Well,
That'd be
Three
more than
strikes
that.
and you're out.
It'd be cool if we achieved this list and then we reached column B 9 months from now. I'd love that.
did you have a comment? Did I see a hand
Yes.
poke up a little bit, Mike?
Yes, Mr. Chair, if I may address the board regarding Diamondville. I know last month we discussed it on how we could mitigate the costs out there, at least in the short term. And the numbers we were working with last month that I had shared with the board, Dan asked me to be really careful about that. And so I want to make sure that you understand those were things we were considering at that time. Right now, we're finding that costs, even to rent a building, the cost to get it put in place and the cost for the utility extensions they feel really exorbitant. They feel like it's too much money. So we're honestly, we're taking a little bit of a step back. We're gonna go out and see if we can find another solution that is just, in essence, maybe renting a storefront that's available that might fit the bill, or something like that to get us through a short period of time until we can afford to do the building that we had proposed originally. I want the board to know that the engineering we have invested in is still gonna be good for us at whatever point in time that we decide to move forward with the building. So that's not wasted money. So I think we want to do something as soon as we can, but we want to make a good fiscally sound decision to get Dr. Stuckey back in Diamondville camera area. So just wanted the board to be aware of that.
Other comments?
Well, that was just, I
Any
was just
questions?
questioning
Okay.
it. I
Any
didn't
over
say
here?
it under it.
Mr. Chair.
Yeah.
So can't we, well, number one, I just want you to know, this talk of you, that you are talking about reserves, I love hearing you talk about days cash on hand like that.
There's a limit to my
It's very,
discussion.
it's very satisfying, isn't it, Phil?
There's a limit to my discussion.
Anyway, yeah. But is there a reason why we couldn't do like on a special project like this, a special CapEx? Can we not approve that during the year as a special?
Yeah.
I mean, as far
Once
as.
we
Why do we have to do it now? Yeah.
You don't, you really don't. But
We're aware of it.
we're making you aware.
Yeah.
Right? I mean, you can say, well, thanks for putting it on the capital project list, but here's your asterisk, is this is not approved and we're gonna have a discussion. Yeah, we totally agree with that. But if we're gonna talk about capital and potential capital, this harvesting concept, let's get it on the record and you know, it at least is noted in the minutes, and it's not, somebody can't say, well, this is the first time I'm hearing about this.
No, I agree. I like those.
So one further point is, I guess what I would like to know is, you know, you obviously laid it out A, B, and C, so we know what takes priority in that category. But the one thing about the special project is we don't know, does that take precedence over B,
And
C,
No.
or does it take, is it kind
After
of
B
D?
and C,
Is
yeah.
that's kind of what, that's,
Yeah.
Again, this is, guys, it's so dynamic. It's where we have these buckets that we need to, as managers, we need to be able to manage, and they're not mutually exclusive. It's just all dollars are green here, guys.
So what if we were to approve A and have everything else approved when we have the money and you need it?
so is the,
Ours is not correct.
but the operational
I'm
plan,
talking about
Yeah,
this.
Right, ours is not right.
It
Yeah.
doesn't have the special product, maybe extra.
I can see Mark.
And B and C would also be there in the discussion but not necessarily approved until they come back. That's another way to do it.
Mr. Chair, can I ask a clarifying question?
Yes.
So the operational plan though includes the CapEx budget, A, B, and C,
The
correct?
cash flow includes the 3.7. If you look at the,
So just A.
no.
No,
if you
no,
look
it's
at
that.
the-
3.7.
It includes-
Oh, yeah, you're
Yeah,
right,
but-
you're right.
But we've got to find 2.7. If you look at the cash flow, right? Just hand it out.
And that's gonna force us to do it out of AR.
Short-term loan.
No,
No.
I don't think out of.
Reduction, please.
Oh, operations. Yeah, if we can get there, but if we don't, right now, with operations,
We don't have a choice.
I could cry.
Well, no, I'm just saying, that's 1.5, you got only 700,000 to find an operations center. If you don't spend B and C.
Understand, but just
Okay.
remember, even though we've gone through the process of saying A, B, and C, there are things on B that
Might need that.
it's gonna be discussion sooner rather than later, right? So I recognize that you're trying to put some stopgap measures in this process. I get it. But ultimately, we understand very clearly the objectives of what we're trying to do here. And we're not going to, I mean, if we're gonna start to head off the rails, we're gonna have a discussion about it.
Okay, so,
Okay. Sounds good.
Scott, please.
So, the guardrail is cash, right?
Yes.
It's the total garbage.
In my role.
So we're not gonna, I mean, Dan says my new position is CF, no.
I love it.
But, you know, we're not gonna make a decision that would, you know, take cash out of the reserve. And just to, my discussion with the bank is that we need to be at 70 days by December 31 to really show, you know, a thumbs up at the bank.
Even though we're obligated to 60.
No, 60 is.
Now,
Monday.
60, yeah, and I agree, yeah, so 70 by December makes sense.
Halfway there.
Yes.
Then the opportunity, let's say, Diamondville really like gets hot and we need to do it. It's already in the loan agreement, the term sheet they gave us originally, right? Finance that over 30 years. Huh?
It was all approved.
It was temporarily approved, now it's kind of iced. But if we're at 70 days and our DSO is where we think we're gonna have it, then Mueller would say, let's just get that application too. For that and the reimbursement note. So it's just kind of, but the lever is cash. None of this can happen. Because we'll never, if we paid cash for $2 million for Diamondville, we'll never hit 80 days. I mean, unless some, you know, I'm just saying. So those are the levers that we'll watch very carefully daily, you know.
And we understand that.
I just wanted to, that's where it's headed.
Any other comments? If not, I'll entertain a motion.
Mr. Chair, I would make a motion that we approve the capital budget A, B, and C at this time, as presented in the routine capital spreadsheet.
I will second that.
And
Special project, are you keeping that in there
No.
or?
You just said A, B, and C,
Okay.
not special
That's what
product.
you're
That's what
verifying.
you're.
That's a separate line item.
I will okay.
So we have a motion by Cole and a second by Mindy to approve actually it's the routine capital budget of 3.7, which includes columns A, B, and C in priority. Diamondville's not involved.
Yes, we'll talk about it.
Well, that's something that's not involved today.
Yeah, not today, right,
yep.
Everybody understand the motion? You have the first, second, Andrew?
I sure did.
Any other discussion? Those in favor of the motion?
Aye.
Any opposed? Okay. Quality Subcommittee, that is Abby. We have two,
Sean.
You were there.
I was there, I would like the, I would like.
does anybody need a break real quick? I know we're not to our total extended time, but.
The potty break was going.
Want to keep going? All right.
Let's keep going.
Who's in charge of the?
Note that we did not take a
I was
break.
there. Sean.
I guess attendance, can you mark me down for being there? Just in case people are looking, I made the
Quality.
meeting, but Sean took care of it.
Sean and I
Sean.
were there.
But you're.
Sean was.
No, you are.
You listen so much.
I think that's possible.
This will be your first shot at it. Go, Sean, you'll do well.
In the, there was two things that came up for approval, so the business, the hospital infection control plan, and the air civil infection control plan. And both of those were approved for next year. A lot of the information, everything seems to be on the up as far as quality and everything goes.
Yeah.
Falls were down. That was cool. And then, I think one thing we talked about was hand washing was kind of something that they were watching too. Was that? I remember that. That was just something that was on the radar. Some of the new projects they were talking about was a patient transport.
Yeah.
So a lot of people are able to get here, but then can't find their way home. It's funny coming from a detention center in the cop background. It was always like, good luck, see you later. So it's cool that you guys step up and let's make sure you get home while you're still in the meds. But they are working on that, and there's a couple of different things they're working on. I guess there's 2 Uber drivers in the valley. So, yeah, so if you guys ever get into a place you need to ride, there are 2 of them. And you guys have those personal numbers that my guess too, so it was a little easier than just jumping on the app, that they can actually contact those employees and stuff. Was there a list? Is that what you guys said you've done?
You've done a background check?
It sounded like there was a quality project to make it more consistent though.
Yeah, it's still in the process.
Great.
Yeah, I'm getting a really
High level,
aspects, yeah. So those are the things, picked up on that, and if there's any items that I missed, please fill in on other.
Just one more thing that I'll add is that we had, 4 process improvement projects that were complete. So, surgical consent, blood cultures, emergency room labs, and peer review process. That was exciting to have 4 really big projects the first year that we've done. Yeah.
Great. Anything else, Sean, to report?
That's all I wrote notes on.
Then we have I think we need a motion to approve 2020, can I call it 26 fiscal year care center infection and control plan, 2025, 2026 care center infection and control plan. That's what it's actually. Motion?
I'll make a motion. I'll second those.
Abby moves, Mindy seconds, that we approve the care center infection and control plan for 25, 26. Any further discussion? All those in favor?
Aye.
Any opposed? Passes. We also am looking for a motion on this would be, doesn't say, but it's the hospital, the next one, right? The hospital infection prevention and control plan for year 2025, 2026. Moved by Mindy, second by Abby. Any further discussion? All those in favor? Any opposed? Okay. Mindy, a report on our,
Yeah, so
and I apologize, I didn't make that one. I didn't get it in my calendar.
that's all right. It
Give
was-
us
You can blame it on me.
So yeah, it was a good meeting. It was our first meeting. And so we didn't have any minutes to approve or anything. So Sadie took the meeting and we talked about compliance. We talked about that there were some policy violations, but no HIPAA violations. They had a couple employees who were accessing their child's charts, and they just spoke to them and made sure that they knew that they couldn't do that through work.
Had to do it through chart plan or
My
whatever.
chart, whatever
My
it
chart,
is.
yeah.
Yep. But they were talked to and things are going good. There was a talk about the anti-kickback and Stark statutes with Dr. Linford, with a tourniquet that he has, and some other physical therapists have developed, and so we discussed that. Medicare conditions of participation, there was a complaint filed that the state contacted the hospital about, but it came up that the patients were just happy with the hospital, they weren't upset, so anyway, don't understand quite.
Don't you get to face your accuser?
Yeah, I mean.
Well, the
Somewhere in
patient
there.
did.
Well, I know,
patient
somebody
did,
else made
yeah.
the complaint.
They didn't file the complaint.
Yeah, they didn't file a
Somebody
complaint,
else
the
did.
patient, somebody
So
else
you
did.
can just
so-
file an anonymous complaint?
Yes.
And it's,
But they,
People write anonymous
Yeah.
letters about me
I
all the
know,
time.
that's why I don't like it. It's not according to American rules.
but they found out everything's good, the patients didn't have a complaint, they loved the hospital, so it was
Face
fine.
your accuser.
Billing and coding, we talked about, the last 2 years, the state has had a push to reimburse the Medicare reimbursement rates. And we have seen our reimbursement rates improve during this time. Sarah talked to us about, looked at it and researched it. And we are increasing room rates on August 1st to try and capture the eligible charges.
Sure, it's not roommates.
No, it's not room
There-
rates.
It is gonna be a roommate situation, right? Because there are single rooms going to double, right?
Oh, you
That's
have
a big
shared
thing.
rooms,
Or
huh?
not, right?
No.
We've always had semi.
Oh.
Semi-private.
Semi-private, yeah.
They are roommates.
Then we talked about ethics. Anyway, there was a patient, we talked about that. And Chris Hinton, they gave us a technology thing that she had done, a PowerPoint. And we talked about that and how IT and everything has such an AI and all that kind of stuff has such a big thing to do with that now, and it's very important that we keep that in place and keep that going. We talked about OCHN, and we talked about lots of
Let's
stuff.
talk about Ocean. I'm always curious about OCHA.
An OCHA update.
It's the IT.
Yeah, IT part of it, yeah.
Technology.
Anyway, it was a good meeting, and so that was our first one, and it went well, so.
It was every other month, so you get next month off, Marlo.
Yep.
Not this month, but check with me. I don't usually give 8 o'clock appointments, so.
That's my best time, so that's why I did it.
Oh,
I got to pick the time. So if that doesn't work for you,
Screws
we'll
up
have to
my
figure
whole-
something else out.
morning activities. Anyway, moving on.
We can talk about that at another time.
Foundation report, Jeff's not here. Was there a foundation meeting?
There
No, there
wasn't.
is no report.
There is minutes, but that reflects the previous months that I was at.
Okay.
It just happens so close to board meeting.
So we're on to auxiliary. Was Abby this month?
No, Abby's.
Says Abby.
There has to have been when I wasn't at it though.
Andra?
It was Jeff England, but he didn't make it.
Oh, okay. So do you have any report from auxiliary?
Just in the board pack.
Just the board packet one? Okay, great, thank you. Mr. Taylor, Attorney Taylor, board policy for broadcast recording public meetings.
That it's in the packet, just based on the discussion and direction that you gave last month, resolution 2025-09 to adopt that policy, which basically, I hope, again, incorporates what you had instructed last month. A live stream link will be made available on the website prior to each month's meeting. Make sure there was language in there that said it's not required, it's a courtesy that the board is, going to attempt to do, but if it doesn't work, you can proceed with your meetings without having to postpone or delay your meetings. I also made sure to include in there that because you are recording, that members in the room, or members of the public in the room don't. And that public participation is only allowed in the room, not online. As far as making comments, and that the videos will be retained for a minimum of 12 months, and that you can change this policy by majority vote.
Anybody have any concerns or comments? Oh, yeah, I haven't re-downloaded my packet, so I didn't have that in there. Any other comments? Dale, board members, is it what we want? My understanding is there is not a link on the website for this meeting. It was a second test. And it will be up for the next meeting in July, so they can see it live, correct? It is on the archive, and first one is there. Last month's is on the archives and runs. And this one will get on the archive. Yes, Chris?
Mr. Chair. Yes, so we will be planning to post a recording of this session and make it available again on the website. Whereas this session, we wanted to make sure we have all the live streaming activities in order, and with the executive session in the middle, all protected and parents.
Okay, great. We need a motion. I'll entertain a motion on the recording public meetings, broadcasting and recording public meetings and policy.
I'll move to.
Mindy moves to approve.
I'll second.
Cole seconds. Further discussion, all in favor?
Aye.
Any opposed? Okay. Trevor, would you stand for questions on your report, or give us a presentation, a little bit of where you're at, and then there may be some questions.
Yes.
Dan has already spoke to some of it.
Yeah. Mr. Chair, thank you. Board directors, thank you for the opportunity to answer some of the, I guess, questions or concerns that were brought to last month's meeting from a concerned citizen. And so in response to that, I've actually put together a report. We do plan to make that publicly available on our website, and we have also met with each of the towns, Dan and I and Ryan Ballard, our EMS director, and we've provided that report to each of those towns. So I want to start off, if you haven't had a chance to read the 2017 study that was done on EMS in Star Valley, there's the opening paragraph of this says, Star Valley, Wyoming is facing what can be best described as the convergence of several storms, the perfect storm. First, volunteerism across the area, across the state, and across the nation is declining at an alarming rate. Second, the regionalization of healthcare is demanding more and more patients be transported further distances, resulting in ambulance services already under strain for staffing to ask more of their staff. Third, the ever-increasing cost of providing emergency medical services, along with the ever-decreasing reimbursement for services, result in few, if any, financial resources available to maintain and grow EMS organizations. And finally, the decrease in mineral and energy production in the valley has reduced much of the tax resources available to communities to support EMS. This was in 2017, and at the time, the three different groups decided that it would be a good idea to get together and work on a grant to have a third party come in and do an assessment of EMS in Star Valley. So that assessment was completed by Safe Tech Solutions, a third party. And the next thing they say in here, Star Valley does have 3 ground ambulance organizations. However, at least 2 of these organizations are struggling to meet all requests for service. And as operating today, they do not appear to be sustainable long-term. All 3 face challenges in financial sustainability, low call volume, long interfacility transport distances, decreasing labor pool, insufficient revenues, regionalization of healthcare demands for ever more sophisticated out-of-hospital clinical care, and workforce recruitment and retention. These concerns, as well as many more, led all 3 ambulance organizations to collaborate in an application to Wyoming Office of EMS and Trauma for grant money to fund an assessment of the EMS systems in the valley. And I'll read one more thing from this report in 2017. They had several different recommendations. One of their recommendations was this: both agencies operating today that are not sustainable should immediately address non-compliance by taking one or more of the following steps: contract for coverage from another EMS agency in a formal written agreement for uncovered hours, suspend operation as an ambulance service and become a first responder organization in which they may respond as volunteers are available, and/or surrender their ambulance license and become a substation of another EMS organization in which they operate legally on a part-time basis under the umbrella of the other agency. So 2017 report, and I think it puts kind of an exclamation point on where things were at that time. Please know that none of this is intended to throw any shade toward any group or individual, and that we need to recognize those people that in the past have spent so much time and effort running the volunteer service. One of the things they point out in the report is that volunteerism, if it gets to a point where there's just not enough people, then the burden on a few becomes too great and they will also quit. So it kind of hits this critical mass where it's just no longer sustainable. They identified that in 2017. So in the latter part of 2021, Dan met with me, asked me if I would be the administrator over EMS and work with him to.
It wasn't a choice, Trevor.
Yeah, exactly. And work with him to try and bring the different organizations together and create one sustainable EMS service. So we did that. It certainly had its challenges. Many people didn't want to go that direction for fear of losing their ability to be autonomous and to run their own stations. But we were able to do that, and I think after a short period of time, people started to recognize the benefit of EMS under one umbrella. So as I mentioned, some of the just challenges before we started to notice even prior to 2021, but it really became emphasized in 2021 when we started getting calls to respond to the Thane and Alpine service areas. And I identify that in the report, but and unfortunately I don't have all of the information from Alpine. And so this is information I was able to get on call volumes and information prior to the merger and after the merger, as well as call times. And so prior to the merger in 2021, Afton EMS responded to Star Valley Ranch, Thane, Bedford, a total of 94 times. The average response time of Afton to that service area is 21.29 minutes. Thane EMS responding 155 times to these same areas, averaged 24.17 minutes. And so even Afton responding to Thane, we were able to have better response times going from Afton to Thane. And again, this is not to pick on any one organization, but really just to try and answer some of the questions that were brought from the citizen last month. So the next page that I have in this report, yeah, go ahead.
It seemed like Alpine in those days was a little better in comparative because didn't they have a full-time guy on? Wasn't their head guy, well, part of the year, and then he left part of the year or something, it seems like, but during the summer, they had fairly decent response times because they had a full-time guy hanging around, right? Okay, just for context.
Yeah, so this is on the third page of the report. It says, despite criticisms of recent operational changes, the data unequivocally shows Star Valley EMS has significantly enhanced emergency response times since the 2022 merger, addressing the unsustainable challenges of the previous volunteer model. For Thane, response times improved from 16.27 minutes, and that was from 2019 to 2021, to 9.58 minutes. 2022 to present is 9.58 minutes, a reduction of almost 7 minutes. Bedford's response times decreased from 23.56 minutes to 18 minutes, almost 6-minute improvement. Star Valley Ranch saw the most dramatic improvement with response times dropping from 26.15 minutes to 14.42 minutes, and almost a 12-minute reduction. Afton experienced a slight increase of their response times from 7.29 minutes to 7.57, but the overall trend demonstrates faster, more reliable responses across the region. The other thing that I'll add to that is that under the volunteer model, I believe Alpine and Thane may have at times had kind of inconsistent paramedic presence, but the responses were not only quicker, but we were able to provide more services when we did respond because we were responding with an EMT and a paramedic. And sometimes we had a critical care paramedic, which is even a higher level of care that's able to be provided. And I identified some of the improvements after 2022 to present. So we went from volunteers to full-time EMTs, critical care paramedic supervisor, and seasonal staffing is what we plan to have in Thane moving forward. Alpine model will have a paramedic and an EMT. Response times are more consistent. We also have oversight from each of the organizations before had a medical director, but now we have all of our oversight under one medical director, and that's huge. It's really important to us that we have that direction and that guidance from a physician, and that's Dr. Oliverson right now, and he does a great job working with our EMS teams. One of the things that we have really tried to watch, and this started about July of last summer, we started counting something called status zero. Status zero is when we have no rig to respond to the scene of an accident. And you'll notice that last summer, and we had 8 in July, 7 in August, September 5, but from July to December, we had a total of 28 times that if there's potential, if you called 911, you wouldn't get a response, or you would get a delayed response because we didn't have a rig available. So part of that was, in order to make EMS sustainable, we've tried several different things. And one of the things that our previous director felt would work is if we started doing interfacility transports from some of the other hospitals in the area. So St. John's, for example, Bear Lake, Evanston, Kemmer. And so we started putting resources into sending a crew up to St. John's to pick up a patient and then take them down to University of Utah. And so I feel that the reimbursements that we were receiving on that was not worth the risk of taking resources out of the valley. So we have since changed that. We no longer have our critical care paramedics or our EMS responding to or going to the other hospitals for transports. We still transport from here. We still do transports from the really long hallway of Alpine to Afton, but we're not going to be focusing on doing those interfacility transports for other hospitals.
Is that why your zero things are decreasing?
Well, I would say it's too early to tell if they're decreasing, just because we're just entering our busy season, and most of what we track so far has kind of been in our non-busy season. So I hope that as we watch that, we'll see that decrease. And if we don't, then we do have plans to have additional staffing as needed to be able to cover that. Yeah.
So you say no rig, is that, like, that's very broad to me. That to me sounds like your ambulance is parked in the garage and somebody lost the keys. And I know that's not what you're saying. Are you talking like, if they're on another call, there's gonna be a delay time because just recently we had, whether it was a car in the canyon, there was a car in a river, so there was a bunch of stuff happening. Is that where those are gonna show up, or is it things like a transport's going from Alpine to Afton and you have that miraculous boat crash at the same time?
Yeah, it could be a number of different things. It could be it's just that our resources at the time are currently busy. They're being used either in a transport or another 911 call. I think was the 4th of July last year that we really had a kind of a crazy day. We had an airplane crash and all sorts of things on the same day, and it was taxing. What we don't have in here is the number of minutes that, and a lot of times that's what this is. It's minutes that
we went over our threshold, so we have to count it as minutes.
And I'm not aware of like a specific threshold that we have to meet, but it is something that we're actively tracking, so we can say, okay, this is not in a place we need it to be, and we need to make some changes with staffing to be able to meet the needs of.
There's no requirement to track that.
Yeah, it's a nice number to know.
Status zero, but it's good to know. Yeah.
So I've mentioned some of the challenges with just the billing and with the sustainability of EMS, but one of the main things that you'll see in this report is that roughly 45% of our calls are non-billable calls. So you're required to respond. You have to show up, but you're not going to recover anything from that call. So that creates a challenge. And then of the calls that we do go on and that are actually considered billable, our reimbursement or our collection rate on those is about 38%. So what we bill, we collect about 38% of that.
So why wouldn't we be able to bill? I mean, we send the ambulance out, they show up to the house, help the people from a fall or whatever.
Yeah.
Put a Band-Aid on, take care of something.
I think more of it, Marlo, is, or Mr. Chair, sorry, is that we respond, someone calls 911 for their neighbor. We respond to the neighbor's house and neighbor says, I didn't want to do that. I don't need any services. Or we respond to the scene of an accident and they refuse treatment or transport. So that happens.
Can they also say, we need you to take you to the hospital, but they don't want to ride, no, we'll take ourselves.
And legally, we can't go for that.
Right. So we have looked at and we can continue to look at opportunities where we can make improvements there, but it's.
So in any situation, they can choose to take themselves, or is there an override by either an ER doc talking to a paramedic or a paramedic to say, no, this is life threatening, you gotta get them?
Yeah, I might, sorry, Dr. Cowan, can I defer to you on that?
Patients have a right to decide how they receive care. The challenge becomes in deciding whether they are of an appropriate mindset. Are they capable of making that decision for themselves? And so sometimes, yes, there is a judgment call.
Okay.
I think it's important, and we talked about this previously, but I think it's important to know that this is not unique, this status zero, as we call it, to just Star Valley. It's everywhere. There is a dearth at EMS. I mean, you expect instantly, and that's the expectation. It's not possible. And for that reason, and other reasons we talked about today, that's why hospitals don't run EMS. But certainly the Valley benefits from what's happening. Yeah.
Thank you.
Yes.
To further highlight the challenges, and I'll just kind of close with the information I have on the financial metrics for 2025. We had gross patient revenue of 4.5 million. After our contractual adjustments, our net patient revenue was 1.5 million. Expenses, and one of the things the 2017 assessment reports on is that people rarely account for the amount of benefit you get from a volunteer service hour and how that impacts your expenses. And so when you go from a volunteer model to a paid model, your expense is immediately going to go up because the labor is no longer, I guess, free, so to speak. And so they had some metrics they identified in the report, and I can provide that report to each of you, but it's good to read through and just see where it was in 2017. Our expenses for salaries, wages, and benefits, and this does not include any salaries and wages and benefits for anyone other than EMS. And so it's EMS director and EMS staff. This is not hospital staff or any others that are not included in there. So total operating expenses of 4.5 million. And so the other, I think, thing that we've heard maybe from the community is concerns about spending and how much we spend on equipment. It is important to watch those things, but it's also a very small portion of the overall expense of EMS. It's mostly salaries, wages, and benefits. So after we take the expenses and the revenues, and if we were to take the entire county tax levy and apply that to just EMS, that was 2.1 million last year, and then 33,000 from Star Valley Ranch, Bonneville Alpine Fire District, and Jackknife gives us 1,500 a year. And then we had we sold one of the ambulances to replace that, and we had a gain on that. Net income loss last year was 821,000, and so it's a significant loss. In April, we made the decision that we felt like we needed to gain some efficiency, and so we changed our staffing model in Thane. We went from an EMT and a paramedic in Thane and we reduced staff there. And now that station is being staffed by an EMT and the paramedic supervisor. So we've always had a paramedic supervisor on. And so basically the change was moving the paramedic supervisor into a working role where they're actually working as a paramedic and responding to calls. And so Thane still has the coverage. Today, our schedule is fully staffed to where we can have a full crew in Thane. And we plan to continue doing that through our busy months. And then as needed as things start to slow down, we do plan to have just the supervisor there, and they will have their response unit. They will respond to the scene of the call, and then they will be backed up by services from Afton and Alpine. And
Question.
Yes.
So you're saying prior to April, we had 7 people 24/7 on call at any one time. We had a supervisor that was a critical paramedic, and then a paramedic and an EMT, at least a paramedic and EMT, and some of those might have been critical at the other 3 stations.
Yeah, and sometimes,
7 total.
yeah, and that was for each of the stations. And
then after April, when we made the change, we now only have 6 people 24/7 because the supervisor, who's a critical paramedic, is stationed in Thane.
Yes.
And is ready to run with an EMT. So now we only have 6 people full-time, and that was the savings.
Yep.
Okay.
And by doing that, we were able to save about 4.5 million in, or sorry, not 4.5 million. We're able to save 479,000, or we feel like that's what we'll be able to save
in a
year's period of time. And so what I did is I took last year's information. I didn't add any increase in revenues or anything like that, but I just wanted to get a comparison of where we are today with last year. And even after the savings, we feel like we're going to have a bigger loss this year in EMS. Our loss will be closer to $1 million. So we saved almost 500,000 in expense, but we have reduced county tax monies this year. And so after that, our loss will increase to nearly $1 million, or over $1 million.
So, Mr. Chair?
Yes.
Did we do the right thing?
Yes.
Because,
I think so.
Because if we didn't act, if we were proactive with all the other pressures that we have, what's the result? And so the admin team, we strongly believe that we are trying to be as proactive as we possibly can, including taking the lead on meeting with all of the county and town leaders in solving this problem. So recognize that there's going to be some strong opinions about EMS, but vehemently agree or disagree that we are somehow that we're damaging EMS in the valley. And in light of everything that we have invested, everything that we have done, it is entirely unfortunate that there isn't any grace
Pat on the back,
or pat on the back, or whatever you want to call it, of what this organization is doing to bless the lives of people in this valley when it comes to emergency services. And is it our fault that we're not telling that story? I don't know. But let's start telling that story, because we're not going to sit back and say and have people say otherwise. I think they're leaving out a lot of facts. I think that they're taking facts and using them for whatever argument they want to make. But without Star Valley Health, this entire valley, I believe, would have a very poor EMS service.
Just to add to that, go ahead, Abby, and then I'll follow.
In Thane, if you've got the EMT supervisor, they're able to report to the scene, but if the person that they're treating needs care, is an ambulance coming from Alpine or Acton, or they can't drive and take care of a patient?
Correct.
Like,
Right.
I just want to clarify like what that looks like.
So as of right now, and through our busy months during the summer, there is a rig ready to go, and they respond with an EMT on that rig in Thane.
For the summer, for the crazy summer
People in
months.
the crazy summer.
Awesome. And
And in the winter, when things slow down, they will have a response vehicle. They'll go to the scene of the accident. They'll start interventions, and then the EMT will respond from either Afton or Alpine.
depending on
As
that mile
available.
marker or the severity. Okay,
Or where they're at.
other question. Do you know in the time that you made the staffing adjustments, not like an exact number, I'm not like holding you to this, but can we compare response times on average? Have they drastically increased or decreased, or are they about the same even with the staffing change? Like that would be a number I could say, well, we're still responding at the same time or similar.
Yeah, I haven't pulled that data, but I can certainly get that. I can
I
get,
think it would be helpful for the
If
conversation.
there's been a diminishing
why would
of
it be any-
services from what we.
But why would it be any different? All you have is the guy that was not in a vehicle, that was the supervisor, not.
People make the case that that decreases people's ability to get attention, and if we can say it was
How can it?
21 minutes and it's still 21
Yeah.
minutes, then we are easily able to say by the math, we're providing the same level of care with
And
less
I think
people.
we're gonna find that the time's the same, but what I'm
I
saying
think it's
is
helpful for
the
Trevor.
supervisor never traveled. He wasn't responding. He was
Yeah,
just
no,
on
I get that, but
call.
we had two people we were paying to respond together.
no, the supervisor did before,
Yeah.
would
Somewhere
also
else.
respond
Yeah.
Oh.
using so let me clarify that. They would go help wherever they felt they were needed.
Okay.
So if they were needed in Afton,
So
they
you actually
responded
had
to
three
Afton.
Three showing up to every scene.
But even,
You know what I'm saying?
totally, Abby, we totally agree. We'll get you that information. So you're,
It's now I'm like dying for the information, I'm just curious.
you know, we'll get it for you. But one other data point is in the report, what were the response times pre-2021?
I get that. The narrative looks like we're back to where we were before the convergence of, but really where we were pre-Star Valley Health taking it, I think the towns would have bankrupted the program or the volunteers would have burnt out to the level that I think everybody's driving themselves to the hospital because they've already said, I die or I drive myself.
Mr. Chair, can I address that? 2017, two of the agencies were not in compliance
Sure.
with even being able to respond as an ambulance service. It was recommended by a third party that they surrender their license. I think it's really important for the town and the community to know that fact, that they weren't even sure if they were in compliance. So we've never been there. And so even with the changes we've made, the service is still significantly better.
I agree.
So, Sean,
Is there not some money that comes from Afton and Alpine? When I was in law enforcement, like they had to pay the county to be there or have their own law enforcement.
BMS.
So, well, just in law enforcement, they had to do that
Oh.
because it was a first responder.
That's-
In order to be a city.
but
they had
that's
to
what-
offer fire.
is
that what that?
EMS is not an expensive, so the sheriff's
So fire-
department,
Fire and law enforcement is, but EMS.
the sheriff's department contract is with Star Valley
So
Ranch,
that's what Alpine's having.
Yeah.
Alpine and things.
So the problem with EMS here and as well as in the country is nobody owns it. Nobody says that's somebody else's problem. Because you know what? I'm not obligated as a mayor to fund EMS, so I'm not gonna fund EMS. The county, it's not essential service, I'm not gonna fund it. If we didn't step in, we would be in a heck of a totally different story than we are right now. And so the hospital right now is in a lose-lose situation. Here we have invested and done everything we possibly can to make EMS better, and we have. And now if we make any type of adjustment to it, there is hell to pay.
We're accused that we're not standing up to a standard, so.
Mr. Chair,
Cool.
one thing that I found when we got this report in Finance Committee, I thought was a really great idea, and Trevor, correct me here if I get this wrong, but my understanding was that if we had Afton's ambulance and the people we have staffed in Afton respond to an accident or whatever, respond to an incident, it sounded like that they are proactively moving
Another unit.
another vehicle from Thane or something to kind of midpoint between Afton and Thane to also help provide better response times should another incident occur this way. Is that correct?
Yeah, and that's Ryan did mention that, and I'm not familiar with the details exactly how they move different rigs around, but I do know that according to Ryan, that if they have a response, if Thane's on a response and now they're out of service, that he said they would move a rig more towards the Narrows so that they could be better situated to respond to either area.
So they're communicating between the three.
Yeah, absolutely.
And the importance being is the time of response is significantly less should they have a second incident.
Kevin, comments?
They didn't. That happened and continues to happen. Unofficially,
Yeah.
response times are the same.
Cool. Right, and honestly, that's all I was looking for, really unofficially.
I don't have,
Yeah,
from those that keep track of those numbers, it's not an official report yet. Response times are the same. Now, we haven't hit July,
Yeah.
sure, yeah.
and I think that's important to remember.
I think you're zero people on whatever, that number.
Zero status.
The zero status scares me a little bit, and I think now that you've started tracking it and that has some value, it's like our medication errors that we're catching or whatever, like we kind of rate them, so it's like, did we not have it because we were driving something from Afton to Alpine, or because there was multi crashes? Those two scenarios are very different to me.
But you're
You
never.
can only
gonna
have
be
so
able
many
to-
rigs, I get that.
You're never gonna be able to have enough rigs to take care of every
I
situation
know, I
every
agree, and
day.
I think everybody
Which-
understands that.
Which I think we need to recognize. The comment that I heard from Mackenzie was, you have enough snow plows to take care of the plow or the snow that day, right? And if there doesn't snow, you still have everything ready to go for the worst day. But
That would have
there's
like
a
8
timing
minutes.
on snow plowing. My road doesn't get done as early as Highway 89.
For sure.
There's a criteria of stacking.
It's not a fair comparison.
And it's gonna be a triage for EMS every time
Mhm.
if we have multiple instances where they've gotta go, a fire, a wreck, the police are out chasing somebody over the hill, we're gonna get spread thin, especially in the summer. So one of the things that I was thinking of, Trevor, in the 2017, by the way, Mike, did we find a grant, or I thought the hospital paid a matching amount or something?
Mr. Chairman, it was funded by the state of Wyoming. I think the total was like $14,000, something like that. For the
We didn't have to fund any?
No, we
Okay,
didn't, no.
then I misremembered that. But what I find very interesting from my personal standpoint is and I was here in 17 and remember when they made that presentation. And we have accomplished, one of the important things was because there were 3 separate entities operating ambulances, they could not recover costs from Medicare at the highest that they should have because they're competing and within 30 miles of each other. So by bringing it under one umbrella, we gained greater efficiencies, and that was one of the recommendations. And I think, to your point, Dan, that's what we've done. We've started somewhat down the road with this study. Now, maybe it needs to be updated. I don't know. I would bet it's not changed a whole bunch, but Maybe because it's 8 years old, it might need to be updated, but we're headed down the path, and that's, tonight, I think the board, there's no decision for us to make, except you need to be thinking, in my mind, what is our role? What do you want our role to be as the hospital? Because it'll come back to this board to decide what kind of a partner we are. And Dan started it so that we're gonna have the discussions with the communities. It is a community problem to solve, and I think, at least the meetings I was in, I think they all recognize that it's a community discussion. I don't know that anybody wants to pay for it. And they may think that we've got the deep pockets and I don't pay for everything because we get downstream revenue or something. I don't know what they're gonna think, but it's gonna be a decision this board over the next 16 months, I think is what it is, right, Dan? We're gonna need to make a decision of what we want it to look like and how we're willing to participate. Nothing to make the decision on tonight. But I'm afraid we've spoiled Valley by giving them the Cadillac when they had the Volkswagen. Not anything against the volunteers, because I remember as a young married with a young family.
Yeah. Exactly.
Having them show up.
Yeah.
So.
That's why the zero, but yeah, I get it.
But we can't solve all the problems.
Mm-hmm.
So anyway, it's gonna be a big discussion. And as Dan said, there's gonna be a lot of opinions. And I'll finish and Cole, you got a comment.
I just wanted to touch on, so the one thing that was shared with us as well was on the status zero, going back to Abby's comments and some of that, is it is in a lot of EMS situations, especially in more populated areas, but it's very common for them to have status zero, a number of status zero, and at any particular time have a wait list of, hey, we've got 9 calls waiting to attend to, and they all have a priority list.
Sure.
And so it's very common. So when Marla talks about the Cadillac or version or whatnot, I mean, I think we're pretty fortunate that we don't have very many status zero, but I think if you look and compare it to other EMS organizations, I think we'd be an outlier from the standpoint that we have a smaller number. And
the status zero doesn't mean we don't show up.
I know, that's why
It's
I'm
just that
saying,
we're
the number's
slower to get
important
there.
to know. I'd like to see, I know it's a lot of effort, but like what the reasoning behind it, because half of them might probably be like, yeah, like, was it one of the 44% that you didn't show up, but they weren't even gonna need you anyway? I don't know.
Yeah, but you gotta show up.
Furthermore on that.
I know that, but it's like nobody died because we didn't
Right.
come.
Yeah.
Some of the resources were out, I guess, being used in transfers. And my understanding is that we're not going to focus as much on the transfers as we previously were, the
Yeah, that's what
external.
We will still certainly have transfers, because there's times where the only way out of here is by ground ambulance. But it's just, we are not focused, we're not gonna go to St. John's, pick up patients and take them to University of Utah.
It did seem like a good idea to look at, and it's great to have numbers to say that was a terrible move for us.
We've pivoted again.
Yeah.
We made it a good one. All right, any other thoughts, questions on EMS?
How are you gonna you said you were gonna give this to the staff or a few people?
We're putting on a website.
A website.
And I assume we're gonna mail this to Mackenzie as our answer.
Yeah, we can provide it to Mackenzie. We are planning to put it on our website, and we've given it to each of the towns.
Attorneys, do you have any suggestion on that, or we were just gonna mail it to her and here's our response?
She responded to the offer to, go ahead, what's that?
She'll be here at 2:00 tomorrow.
Provided.
Yeah.
Hand it to her?
Yeah, that's whatever.
Note somewhere delivered by hand.
Maybe Dr. Cown's little side note that response time's similar.
Thanks, Trevor.
Thank you.
Chief Executive, CEO report.
Mr. Chair, to save time, I'm not going to go through this in detail like I did last time, but there are 2 things that I want to state. Hey, Mark, before you go, one of them is, while he's here, I want to recognize Dr. Mark Cowan. Under number 4,
not do that.
Mark? Under number 4, medical staff leadership. Our chief of staff, Dr. Mark Cowan, continues to do a magnificent job of reaching out to providers to help facilitate improvements in their practices. Along with other physician leaders, he's constantly reinforcing the fact that we have a great team of providers and staff. He did that again today. He's been consistent in helping people understand we will continue to be a successful healthcare system if we concentrate on exceptional and compassionate care of our patients. And we feel very fortunate to have his leadership. Like he said, we're lucky to have a lot of our providers. They don't have to be here. And they want to be here, and they're willing to work through the challenges. And it's because of his leadership, along with his, the other doctors that he's got helping. We are a very fortunate organization to have the medical staff that we have. So thank you, Mark.
Thank you. I appreciate that. I gotta go like work, but one parting shot. We've sat here tonight and we talked numbers, and I understand it's a business. But just like I tell everybody else, not lose sight of why we do this. Don't do it for the numbers. It's not why we're here all night. And it's important that every one of us understand that. It's one life at a time.
Thank you.
Thanks, Mark. And then lastly, I want to make this a public record. So this report, we're going to we send it out to all of our staff, to the board. We're going to send it out to the staff. They'll see the strategic plan. I do want to verbally say there has been no substantive progress in the negotiations since last reported with Cigna. If no deal is reached by the end of this month, and it looks like there will not be a deal, we will work with each individual patient with Cigna insurance on how their out-of-network benefits can be applied to Star Valley Health Services. Negotiations will continue, but our focus will shift to assisting patients with their specific needs and concerns. Letters will be going out to every single patient, giving them a specific way that we're for Cigna patients only, that if they have questions about how they can receive services and how we can work with them, we're going to do that. It all depends on their benefits. And every employer has different benefits with Cigna, different contracts. So a Cigna patient is not a Cigna patient, is not a Cigna patient. We have to work with them each individually. So I want you to be aware, the public to be aware, that there is a very unfortunate reason why these patients are being put in the middle of it. In an executive session, I'll give into more detail because of the sensitive contract negotiations. So I'll update the board on that, but I just want to submit this report, and it has been submitted to you, okay?
Thank you.
Okay, I think we probably solved. Next meeting is our meeting change will be Tuesday, July 22nd, is that right? At 2:30. Instead of
We're gonna make it the 30th.
the 30th of July. So we'll need to announce that as a special meeting.
I make a motion that we move July meeting to Tuesday, July 22nd.
Second? Moved by Mindy, seconded by Sean to move our July meeting to the 22nd of July at 2:30 p.m. here in this room. Any further discussion? All in favor?
Aye.
Any opposed? Okay.
That's the 22nd?
Tuesday, the 22nd.
Okay, got it. I just want to make sure.
Got it in your calendar?
No, I don't know if I have it.
I will change that tomorrow for everyone.
Okay, and you want to say anything about the employee picnic? It was last night for those that went.
Great turnout, great food, great activities. It's a great tradition. And it's a way to just celebrate the wonderful people that work here.
Okay. We need a motion to go into executive session, and I think, Brandon, you have
It's
a
in on
motion.
board, right on your little, where it says executive session, it says what the motion should.
Oh, it's on the agenda?
For real estate matters.
Somebody needs,
Well,
no, we want
For the
all
whole
three.
thing. Where is, here's one of them, we can have that.
Motion.
We've decided to do a
I'll do it.
prescription.
Okay, I move to go into executive session for the purpose of considering the acquisition of real estate, personnel matters, and matters concerning litigation to which the hospital district is a party or to which the hospital district may be a party.
Second.
All those, any discussion? All those in favor? Any opposed? We are gonna take a 5-minute
Now,
recess.
Mr. Chair, we talked about.
Oh, who needs to be here?
Making sure that we know who needs to be here.
All those who would like to stay that are admin and board. We'll let the public go. Anybody have that wanted differently this time? We'll keep it that way.
Okay.
Like, don't feel bad if you want to go home. Right? You have to stay.
Yeah, does the board have an option?
I didn't talk to you. I was
So,
talking to
I'm just happy.
it was advertised as part of the.
Part of the
board-
meeting.
As part of the board meeting.
So we're good to do it now. It wasn't
You're
at
good to
5
do it
o'clock.
within your meeting, you don't need to adjourn into another meeting, but you do need to call and
Yep.
for public comment. The statute requires 3 things: that you advertise for it, that you
Discuss it.
call for, that you publicly notice it, you give the.
There's my 3 times. I feel like a crier. In England.
You've been in enough town council meetings, Mr. Chair.
I have never heard it.
Seen this 1,000
I have never
times.
seen the 3 times on a public hearing. Never, actually, in 40 years. More than 40 years. Anyway, seeing no public comment, none of the administration wants to be public and make any comment? We've hashed it pretty well anyway. I now close the public hearing for the fiscal year 2026 budget for North Lincoln County Hospital District. Andrew, I'm sure you'll get all the right minutes there. And we've already passed the motion on the budget, so. So I guess my question is, should we have or insert this public hearing before we made the motion on the budget?
I mean,
In the minutes?
you could ratify that, acknowledge that the public hearing should have happened before, it didn't, but you still have the opportunity, and now, you call for a motion to ratify the decision that you made prior to the public comment.
Okay, I will take a motion to ratify the actions that we took on the operating budget.
Second.
Any discussion? All in favor?
Aye.
Anybody opposed? Have
Motion
we
to
taken
adjourn.
care of everything we need to, Brandon, on this deal? Sorry, I was so bad at it. Okay,
Second. Do you accept that, Mr.
meeting's
Chair?
been adjourned.
Hey, everyone, this good man's, give him his birthday.
Happy birthday, let's